They are the ones who have the white hair. It's the word vitreous. It's a taboo. It's a problem. And every time the word vitreous comes, the heart starts pounding. The absolute tremors which pick up and you start sweating. Now, vitreous is generally, as Mohan would agree with me, the only people who don't get vitreous in life are two kinds of people. Those who don't operate, or they are gynecologists. So every surgeon worth his salt who has touched any eye is during his residency days, undergrad, postgrad, and during his, even after the 1 lakh surgery, 100,000 surgeries, he's going to get vitreous. But to simplify, how to cool your nose, how to breathe well, how to ease down at that particular moment, how to prepare yourself subconsciously. It's like, that fire drill. It's what you do in earthquake. These are things which have to be so much deep down in your subconscious that your full theater, all your OT staff, all your colleagues, everybody should be ready. What is the next step to be done instead of panicking? First, breathe well, take a deep breath, and just cool down. Take your time. You're not running against time. And what next that you should be doing is what we are going to be discussing for the next 2 hours. Vitrectomy for anterior segment surgeons. Everything you always wanted to ask about vitreous and were afraid to ask is what is going to be taken care of today. We have our moderators with me, my colleagues, Dr. Rohit Om Prakash and Dr. Gaurav Luthra. Of course, they don't need any introduction. Rohit is a chairman of the Om Prakash Eye Institute. The technologies which he has published is the flap motility sign, the trypan blues staining technique, the IOL scaffold in Morganian cataracts, rapid technique in soft cataracts, and nucleus scaffold technique. Every time I talk to him, he's come up with some great ideas and he's always come up with something new. This morning, trying to catch him was difficult. He was already getting on to his posters and other presentation for the AO. Wonderful. Thanks so much, Rohit, for being with us today. And my next moderator is Gaurav Luthra, man of great significance, an absolute man of IRSI. During the full lockdown period, all the webinars till today cannot be having an absence of Gaurav. Gaurav should always be there. And he's the Gaurav of the IIRSI community. He's the chairman of the ARC, Intraocular Implant and Refractive Society of the Dehradun Ophthalmic Society, chairman of the Award Committee Uttarakhand, member Scientific Committee, All India Ophthalmologic Society, co-chairman. As you can read, there are so many things that I don't want to take time further on that. I will keep talking about Gaurav for the next 2 hours otherwise. So he has been the gold medal for IRSI, joint gold medal. He has been an anchor for a lot of things with IRSI and the All India Ophthalmic Society. Thank you, Gaurav. Thank you so much for being with us. And of course, we have a great list of panelists who are going to be with us. Dr. Mahipal Sachdev is there. Dr. Lahane, our guru from Bombay, who's going to be there with us. Dr. Partha, and of course, Dr. Mohan Rajan with Dr. Anita Agarwal. I pass on to, so Professor, would you like to talk about Rohit? I pass on the mic to you.
Yeah. Thank you, Dr. Himanshu. In the panelist list, we have the great Dr. Mahipal Sachdev, who is the President, All India Ophthalmological Society, and he's the Chairman, Scientific Committee, IRSI. He's the Managing Editor of Indian Journal of Ophthalmology, member of the Governing Council of Red Cross Society of India. He has won numerous awards, orations, and distinctions in India and abroad. Then we have with us, the next in the list is Dr. T.P. Lahane, who needs no introduction. He has performed more than 162,000 cataract surgeries successfully. He was awarded by the Government of India in the year 2008 by Padam Shri. He's the Director of Medical Education and Research, Maharashtra, and has been handling 18 medical colleges and multiple paramedical colleges. Associate Editor of Indian Journal of Ophthalmology. So these are some of the few things which we know about, which everybody knows about him. Then we have Dr. Anita Agarwal, who is a vitreoretina specialist. She has her roots in India, but she's practicing in West Coast Retina and works on patients in San Francisco, Cote Madera, and San Mateo. She did her post-graduation from Chandigarh PGI and she has 93 peer-reviewed articles. She has won so many medals like the 2015 Optic UK Medal Award, the Donald M. Gasp Medal from the Macular Society for Excellence in Macular Diseases. So she will be in the panel who would be exclusively from the vitreoretina part of the specialization we have. Next in the list is the great Dr. Professor Mohan Rajan, whom each one of us know. He has more than 2,000 presentations. He's basically a vitreoretina specialist who did his fellowship from Shankar Nethralaya and is now a full-time anterior segment surgeon. Next in the list is none other than our own Partha Biswas, who's the director of BBI Foundation Kolkata. He's the chairman scientific committee AIOS, and he is the one who's live wire and who is taking Indian ophthalmology to the next level. So I would like Dr. Gaurav to introduce the speakers so that we can start with Dr. Shell. Over to Dr. Gaurav.
Thanks, Dr. Rohit, and thanks, Dr. Himanshu, for doing all the excellent work in putting this together. And it's really a subject close to my heart. And today, our first speaker is Dr. Shell Vasavada. Now, he may look young, but believe me, he has a brilliant brain on his, which works really well on these areas. Now, he's a cataract and refractive surgeon at the famous Raghudik Eye Hospital, and I'm sure all of you are fully aware of, the accomplishments of Dr. Vasavada, but Shal is nowhere behind his renowned dad. He's done a fellowship in cataract and refractive surgery at the Moran Eye Center in Salt Lake City, Utah. And he has been winning awards after awards, and I'm judging film festivals and I keep enjoying. And I have to kind of, every time there is a film festival, I know that Shal is going to come up with yet one again a big grand prize winner. He won the Posture Perfect Ergonomics for the Ophthalmic Surgeon in ESAS 2019, amongst many other, best film awards. And he has more than 10 publications. He's a brilliant surgeon and excellent speaker. He will be speaking on the anatomy of anterior vitreous for the cataract surgeon, and a couple of other things, including vitrectomy, whether to go limbal route or the pars plana, the pros and cons of each technique, and for the anterior segment surgeon who are always scared to go through the pars plana, how to go about it. So I think all very, very important pearls. And today's course is going to be brilliant. I've attended Dr. Lisa's courses over the years in ASRS and really enjoyed them. And I think we are going to have lots of pearls. So Shell, to please go ahead. And now we have Dr. Lahane sir joining us. Welcome, sir. We introduced you just now. And Dr. Lahane, again, one of the doyens of Indian ophthalmology. We are lucky to have you with us, sir.
Thank you very much, Dr. Gaurav Luthra sir, for this kind introduction, and thank you so much, Dr. Himanshu sir, for having me on this wonderful course. I think, like Dr. Himanshu correctly mentioned, posterior capsule ruptures in anyone and everyone who is operated, even in their most senior part of their career, and therefore there is no shame in having a PCR. So this is the classical situation quite often when you are, operating and suddenly there's a break in the posterior capsule and the vitreous starts coming out. And the first thing that we want to do, like Dr. Mehta mentioned, is to keep calm and not to panic. So the instinctive decision at this point of time generally is the moment you see a PCR, particularly in the early stage of your learning, is to just withdraw the phaco probe and withdraw all the instruments out of the eye. So that is something that should never be done. So like in this case, there is a PCR that has been noted. 3/4 of the nucleus is here, but make sure that you don't withdraw your phaco probe out of the incision before the chamber is formed. So with your second hand through the side port incision, inject a dispersive viscoelastic. Now, why a dispersive viscoelastic? Because dispersive viscoelastic is likely to stay there longer. A cohesive viscoelastic acts as a bolus and can come out easily. So inject a dispersive viscoelastic, make sure the chamber is formed before you withdraw your probe. Now, once it's clear that there is a posterior capsule rupture, we need to identify the extent of the PCR, identify whether vitreous has already prolapsed into the anterior chamber or not, and start telling your OT staff to keep a backup strategy for IOL implantation, because you may need a 3-piece IOL, you may need a scleral fixation, or whatever your other preferred techniques of choice if you are unable to do a in-the-back IOL fixation. So the first thing is to assess and look for the extent of PCR. That can be judged either just by tilting the globe in different directions, like you can see here. You can notice the extent of the PCR, and this may be necessary to do that. The way to identify vitreous, no matter however good a surgeon you are, is to inject triamcinolone acetate preservative free. Because whenever there is viscoelastic in the eye, it's very difficult to judge whether the muck that is in there is vitreous or not. And we describe this use of intracameral triamcinolone preservative-free triamcinolone acetonide in pediatric eyes undergoing cataract surgery. And based on that knowledge, we use it as a routine to identify the vitreous and make sure the vitrectomy is done. Now, this is something that all of us need to be aware of, a little bit of the anatomy of the anterior vitreous. We may not be the most brilliant posterior segment surgeons or even great at indirect ophthalmoscopy, but this is something that all of us should be aware as doing cataract surgery day in and day out. So this is the cut section of the eye. And it's important to note that beyond the lens and the ciliary processes, the ciliary body is there, followed by the pars plana, and the ciliary process is the area is the pars plicata, followed by the pars plana and the ora serrata that follows that. For us, the important distances to know are that up to about 2 to 2.5 millimeters is the area extending from the limbus to about 2 millimeters is the region extending up to the pars plicata, and just beyond that. And the area from 2.5 to about 4 millimeters covers the ciliary body, the pars plana and the ora serrata. And it is at this area of the ora serrata where the vitreous base is attached very strongly. That's where maximum traction is likely to occur, because we are likely to be working in this area. So we need to be careful about that. These are photographs from the world famous Professor Jan Ver's books to show that the vitreous not only have attachments to the posterior capsule and other areas in the retinal segment, but also there are ligaments which have important roles when we talk about vitrectomy and PCR. And it is this area of this Berger space, or this area around the posterior capsule, which is typically free from anterior vitreous, unless the vitreous is completely liquefied and a complete posterior vitreous detachment is done. These are intraoperative photographs from pediatric patients where a PCCC has been done, and just staining the anterior vitreous phase with triamcinolone, no vitreous disturbance. And notice the exact tracts and all the structures that we typically see in the books are actually present when the vitreous phase is solid. There is no anterior or posterior vitreous detachment. So these are pediatric eyes showing the wonderful vitreous anterior vitreous anatomy and the tracts present in the vitreous body. Posterior vitreous detachment is something that can affect and is likely to be present in many of our patients, adults or elderly patients who have undergone, who are undergoing cataract surgery, who are likely to have PCR in them. What we must remember is that we have not only to make sure that the PCR doesn't extend, but we have to make sure that whatever maneuvers that we now further on do after the PCR causes minimum traction on the various attachments of the vitreous and the vitreous base. This is a very basic but a very simple animation to show the effects of this. This is a cataract surgery, and notice in a while the anterior capsule will split, and this leads to an extension into the posterior capsule, and typically one fragment, half a fragment, and things go. When you think it's just behind the posterior capsule, I can catch it either with a Vectis, or I can go ahead with the phaco probe and try and levitate it from behind up. But what we don't realize is the tremendous amount of stress that we are causing here to the various attachments of the vitreous, including the base, including at the macula and the optic disc. So the best treatment for a sinking or a dropping fragment is to just what we call as the bye-bye technique. Just let it go and let the posterior segment surgeon take care of it. We have to, our aim is to do a good vitrectomy around that area so that it makes life easier, and the long-term outcomes of this eye will be better. So you may get an ego boost by pulling out a fragment from the anterior vitreous phase and placing an IOL somehow or the other. But that is not the only aim of just putting the IOL in the eye. The aim is the long-term good outcome of the patient. for which we may need to even do an aphakia. And this is a video we borrowed from a retina colleague to show how the vitreous is wrapped around this nucleus. And imagine just manipulating this with various instruments, levitation, so on and so forth. The amount of stress that this is going to cause to the various attachments of the vitreous. And therefore, you will always see posterior segment surgeons doing a complete vitrectomy and freeing whatever, this is an entire nucleus, but it could be fragments or anything from attachments of the vitreous before you do any manipulation of that. So that brings us to the goal of vitrectomy, is to prevent acute intraoperative vitreoretinal traction and not to somehow remove whatever fragment is there and place the IOL wherever possible. So we need to make sure that we prevent further enlargement of PCR, because we could do a good adequate vitreous removal, and we leave behind a reasonably symmetrical uniform support for IOL implantation. Another important tip that we learned from Dr. Steve Charles and his wonderful teaching is to never perform a dry vitrectomy or a sponge vitrectomy. So the role of scissors is only and only in extraocular surgeries. Do not use scissors from the incisions. Do not use swabs to try and pull on the vitreous through the incision and cut it, because we don't realize the attachment behind the iris from where it's coming back, from where it's coming. It causes tremendous stress in that area. The second question is when to do vitrectomy, and the answer to that is very simple. Whenever vitreous
Here's another case. We encountered a PCR early in the surgery.
So it could be as early as rexes, it could be as early as fragment removal, it could be as early as as late as end of cortex removal. Now, once you have decided you need to do vitrectomy, which is the preferred technique, or what are the pros and cons of limbal versus pars plana vitrectomy? And I think limbal vitrectomy is something that all of us are very familiar with, because this is how we are used to working from the anterior segment. And this is what is typically described as a top-down approach. If you notice here, you not only remove vitreous from the anterior chamber, you turn your vitrectomy probe downwards so that it doesn't drag more and more vitreous to the front, and you're attacking the vitreous from the top towards the bottom. The disadvantage of this is an animation created by my colleague Dr. Samresh to show that when you're pulling it from above, what it does, it keeps bringing out more and more vitreous or more and more vitreous gel. So what started off as a small regular PCR gets converted into a very large irregular posterior capsule rupture. So the pros for limbal approach are that it's a familiar territory for cataract surgeon. We are all used to working through these incisions, through these areas, and therefore it's very simple to adapt and doesn't require too much of a learning curve or a mental change. The cons are that there are more chances, if you don't follow the principles correctly, of causing intraoperative vitreoretinal traction. The PCR is typically likely to enlarge following a limbal vitrectomy, and this may jeopardize the primary objective to fixate an IOL in the bag in case you were able to convert it into a PCCC. Compare that to the pars plana approach, where you are actually dragging the vitreous from below, from the source from which it's coming. There are less chances of disturbing the posterior capsule rupture, and therefore less chances of further enlargement of the posterior capsule rupture. So the vitreoretinal traction is minimum. Therefore, the vitreoretinal surgeons use the pars plana approach. The consequences to the posterior segments are minimal as a result of that. The enlargement of the posterior capsular tear is minimized, which is very advantageous to us as cataract surgeons. And a fairly adequate vitrectomy is possible in different areas and different directions. The difficulty or the cons of pars plana approach is that it's a very unfamiliar territory for all of us as cataract surgeons. Many of us would not have even done a vitrectomy in our post-graduation training at any point of time. So it's something that is completely new, something that we have never done. It appears intimidating because you feel we may not have the right equipment, the right machinery to do it. And that's the mental block that we have, that I don't have this trocar, or I don't have this kind of, I don't have a dedicated vitreoretinal machine, so how can I do it? The other advantage of pars plana anterior vitrectomy is what I described is that we are able to do a much more adequate vitrectomy around the PCR as well. So we need a scaffold or a support for IOL implantation, which is not just made of the posterior capsule, but the surrounding structures as well. Now, when we do a limbal vitrectomy, with the ergonomics, even if you change your hands from one side port to the other, it's very difficult to remove adequate and symmetrical vitreous from around the posterior capsule. And therefore, you are likely to leave behind pockets somewhere more, somewhere less, which can lead to some, tilting of the IOL, even if it is placed in the back. And compare that to the ergonomical ease of doing a pars plana vitrectomy, where you can notice you're not only able to drain it more efficiently, we are able to easily move in all the areas around the PCR to create a more symmetrical or a symmetrical vitreous removal and a good scaffold for IOL implantation. This is the Miyake view that is from behind for the same principle, to show that with limbal vitrectomy, it's impossible to remove the vitreous pockets adequately or efficiently in all ways. And compare that to this pars plana approach, where your ergonomics are so easy that you are able to move much more freely in different directions to achieve a symmetrical vitreous removal. Let's go through this case example where a PCR has been noted with 3/4 of the nucleus still inside the capsular bag. So the first thing that we need to do is to identify whether vitreous is present in the chamber, and sure enough, there is vitreous present in the chamber. And therefore, the next step is to do a pars plana approach or a vitrectomy through the opening that is already present, the posterior capsule rupture. You need not necessarily have a trocar, and I'll come to that. And notice how beautifully this vitreous gets sucked in through this pars plana approach. And now we have cut the connection of the anterior and the posterior segment, and therefore this tear is unlikely to enlarge any further because the vitreous from the chamber has been drained completely. The same thing even after, this is that same patient, even after the cortex and everything is removed, you can still go back and remove vitreous symmetrically from all around the posterior capsular tear, so that there are no unequal pockets of vitreous left behind. Now, coming to the actual way or the technique of doing the pars plana vitrectomy, the first point of hesitation for us is to make the pars plana entry, and where do we do it, and what kind of equipments and instruments do we need. So remember this photograph. For all adult patients, typically 3 to 3.5 millimeters is the place where from the limbus where you want to make the pars plana entry. So mark it on a caliper. If you are using trocar systems, many of the trocars now have inbuilt 3.5 and 4 millimeter markers. But the safest way is to use a caliper and put it on 3.5 millimeters. Place one end of the caliper at the limbus, what you now you try and separate the conjunctival entry from the scleral entry. So this is not a valvular scleral incisions. Retinal surgeons don't recommend that anymore. What we are just trying to do is that the conjunctival entry is at a different point so that they are not overlapping with the scleral entry. And you go in and screw in as if you want to hit the optic nerve. So we'll do that again now. You go ahead, you pick up the conjunctiva. So now we have just gone subconjunctivally here, not transsclerally or not a valvular incision, just transconjunctival. Turn the tip to the sclera and point it as if you want to hit the optic nerve. Why is that important is that because if you don't aim to hit the optic nerve, sometimes you can tilt your trocar and it can actually go through the zonules or it can hit the posterior capsule. And then once that is done, you can go ahead with the vitrector. With the irrigation from the anterior chamber is a good enough option. So again, notice this, the vitreous, this is after IOL implantation, this was noticed. And the vitreous gets sucked in beautifully through this open area. The irrigation coming from the anterior chamber and the vitreous drained through the pars plana approach. Another important point to remember, when you remove these trocars, it's important to give a counter traction with either metal instruments. Never use cotton because what if there are any vitreous wicks, it can get stuck to that. So this counter traction will make sure that there is no vitreous that is stuck at the entry of the trocar. Like I said, you do not need trocar system. So if you don't have trocar system, there is absolutely no need to worry, or there is no necessity to have a trocar. It's best to do a conjunctival peritomy in such situations because even if you make a transconjunctival lance knife incision, when you have to go in and out, sometimes that becomes a problem. Do the same marking on the caliper, and you can use your same side port or an MVR blade to make the sclerotomy knife. The only difference would be that since this is a slightly larger, incision with this knife, this will be about 1.1 millimeter or so. You will need to take a suture at the end at this port, which is absolutely fine. You can take that with the 10 nylon. Another important point to note here in this video is that we have already sutured the wounds before making the entry. So in a hypotonous eye, it may be quite difficult to actually make the entry. So you may need to take 1, 2, or even 3 sutures sometimes on the main incision to make sure that your chamber is formed, because while putting stress while inserting a trocar or a lance knife, you may actually make it worse by causing the vitreous to prolapse in a hypotonous eye. Another important pearl that all of us need to know is, since this is the part of the phaco machine that we use very rarely, it's important to know how the vitrector works and how the vitrectomy system works. So first of all, we must have all our OT staff trained to use the vitrector, to know how to switch it on, how to fix them, which ports to fix them on, because that's the most common thing that occurs, is that you have the best machine in the world, but nobody knows where to plug in the irrigation and where to plug in the vitrector. It's also important to know that what modes the vitrectomy is in. So the vitrector can be in 2 modes. The most normal mode for us to do vitrectomy is the cut IA mode, which means first the vitrector will first cut and then it will aspirate. That is what we want. So we don't want to pull or drag the vitreous like cortex. So you want to cut whatever is at the vitrector tip, and once it is cut, it will get suctioned out through the vitrectomy port. So in this cut IA mode, the phaco foot pedal has 3 positions. The first is irrigation, the second is vitrector, and the third is aspiration. And based on the machine, it could be just 2 foot positions as well. And in the IA cut, which is something that we rarely need to use, but it's important to know this because you don't want the machine to be inadvertently on IA cut mode. IA cut means that first it will aspirate, and once it is inside the vitrector, it will cut. So there is very limited use of the IA cut. You can use it only once you have done the vitrectomy and some cortex or something is left. So you can use the same vitrector to do the IA of the cortex as well. And here, remember, the vitrector starts when you reach foot position 3 of the foot pedal and not foot position 2. So first you have irrigation, second you have aspiration, and third as vitrector in the IA cut mode. So like I said, the IA cut would, you may consider this as a use once the vitrectomy is done through the PCR, and you have residual cortex. You can use this as your bimanual IA hand pieces, so that once it is suctioned into the vitrector, then it will cut. What are the optimal parameters? Now that's also another important question. So there is no fixed number as to say, but 3 things that we need to keep in mind. The cut rate. So the cut rate needs to be set at the maximum that the machine has. So it could be 800 for your machine, it could be 2500 for your machine, and now with the newer machines like this, the Centurion, you can go even up to 5000 cuts now with the new software. So keep it at the maximum cut rate that your machine offers. The IOP, or the bottle height, should be significantly lower. So if you are working at say 110 or 100 centimeters of bottle height, drop it down to 50 or 60. So reduce the bottle height. Keep a very low flow rate of 10, 12, 14 cc per minute, and adequate vacuum depending on how much vitreous or fragment that you are removing, but typically in a range of 300 to 400 should be enough. What gauge of vitrector? First of all, it needs to be compliant with your machine. So you may have a trocar borrowed from a retinal surgeon which may be 25 gauge, but your phaco machine may not support anything beyond a 23 gauge vitrector. So the gauge of vitrector and the grade gauge of vitrector that the machine is compliant with, that should be your aim. Typically, most newer phaco machines are compliant with the 23 gauge anterior vitrectomy systems. 20 gauge is something that you need when you have a larger incision or a 1.2 millimeter sclerotomy port that you've made. It's important whatever mode of treatment that you do, whether it's limbal or pars plana, it's important to have a retinal colleague examine these patients post-operatively frequently, not only for sequelae at the macula for cystoid macular edema, but more importantly, peripheral retinal evaluation for any inadvertent breaks that may have been created. And if they are identified early, they can be lasered easily. And before I end my talk, just this one case to highlight the importance of pars plana vitrectomy. This is a second eye posterior polar, restore second eye, and fortunately everything was saved until the end. The capsule was intact, but while injecting the IOL, it tilted, and this hit the capsule, and the capsule is so thin that it gave way, which went unnoticed at this point of time once the IOL was placed. Once the irrigation aspiration was started with the irrigation behind to remove the viscoelastic, it was immediately noted that this small area of small posterior capsule which had punctured has given way to a large PCR. So now we have a situation of in the back second eye multifocal IOL with a large PCR. We tried to center it, but of course it never works that way. So we hydrated the wound to see, first of all, make sure it doesn't shallow further. And on injecting triamcinolone, to our utter dismay, there was a lot of vitreous already prolapsed into the anterior chamber. So we went ahead with pars plana approach, having kept in mind that we may have to explant this IOL and go to plan B. But notice in this high magnification how through this pre-existing posterior capsule rupture, the vitreous is slowly, the triamcinolone stained vitreous is slowly getting dragged and sucked in through this pars plana approach through the pre-existing PCR without any further split of the PCR margins occurring. So we have now been able to not only drain that, but remove the connection or cut the connection between the anterior and the posterior segment, and whatever is stuck in the incision then can be removed through the limbal route. We go ahead and then again do a symmetrical removal around the posterior capsule tear. And this is the patient at the end of surgery. We found that the IOL was staying very stable because there was a symmetrical vitreous removal. And this is the patient at 6 months. Now we have more than 3 years follow-up of this patient with an excellent stable IOL in the bag. So I think the main problem that all of us as cataract surgeons have is how do I adapt, how do I change to pars plana approach, or even with the limbal vitrectomy, how do I give the best possible outcome. So I think it's time we change our mindset and have an open mind. Just remember you are going to be working only 3 millimeters away from what the area you are already working so adequately at. Interact with the VR colleagues, and if you have friends or in the same institute, it's best to attend some of their OTs, how they approach the vitreous, the principles that they use. Now with the help of so many such beautiful webinars and YouTube, iTube, so many platforms, there are so many videos available. But I think there is nothing that beats observing in the OR the etiquettes, the OR etiquettes that we as surgeons do for doing vitrectomy. So I think it's time that we choose a road which is not only safe for us, but also safe to the longer outcome of the patient. We need to keep an open mind on how to approach the So with that, I would like to end my talk here, and thank you so much once again for this opportunity and the patient listening.
Thank you, Shell. That was wonderful schematic. I think you gave a super presentation, real practical schematic, real understanding of the anatomy of the vitreous. You know, as somebody said, like the vitreoretina surgeon, Dr. Charlie Garcia told me when I was doing my vitreoretina fellowship, that the pars plana was like a no man's land between India and Pakistan. Out of the area where you could just play around, it was meant for the surgeon. And it's a big area to play around with. You can very easily enter the vitreous. You will not tear the retina. You will not go to the base of the retina. But what you said is essential, that you should know your machine very well. Don't panic. It's not very difficult going for pars plana. And the best thing you did was you don't need like a vitreous surgeon, a 3-port vitrectomy. You just need 1 port which you have to go because your anterior segment is already there. and your irrigation is already there. If you're not very confident, you can put an AC maintainer, because if you ruffle the vitreous from behind, it will feel swirling and more vitreous will come out. So that's something nice which you mentioned that is quite simple. You could open the conjunctiva, take your MVR blade, or you could do your very simple way in which you could do it. And thanks very much. Mohan, would you like to say something about this, being a retina surgeon yourself, simultaneously being a cataract surgeon too? Mohan, you are muted. Mohan, you are muted.
I'm sorry. I fully endorse whatever Shane said. I think it's a brilliant talk. He has opened up all the doors as far as the past planar vitrectomy is concerned. Being both the anterior segment and posterior segment, I was also of the opinion that the anterior approach was much better. But after Dr. Vaswara's technique of which happened about a few years back, I was completely convinced, because nowadays I'm doing only the past planar vitrectomy. The only problem is the certain protocols have to be followed very, very strictly when you are doing a past planar vitrectomy. One is suture your wounds, okay, before you do the trocar and cannula, number one. Know your anatomy very well before you do that, because many anterior segment surgeons do not know exactly what is happening in the past planar and the vitreous. How to put a trocar, putting a trocar and cannula is not so easy like what Shale said. It's not so easy unless you get trained in that. If you're not able to put a trocar and cannula, put a myringotomy knife. Open the conjunctiva, just straight away stab incision towards the mid-vitreous cavity, and I think that will solve the great problem. But I think the take-home message for everybody is that, because many people do not have the posterior segment, and every time they have a PCR, they cannot refer to a posterior segment surgeon. So they have to manage it anteriorly. So that is the reason why many people still prefer limbal, because of the ease and because of the speed in which they are, and because they are more comfortable in that territory. They are known territory for that matter. And limbal vitrectomy also, if you follow certain protocols, you can get away with it. But I think the way to go in the future, as well as now, is the past planar vitrectomy, following all the protocols, whatever Shale, I think all the golden messages, whatever is told in his lecture.
Yeah, Mohan, thanks very much. Basically, as I put it, just take a few guinea pig's eyes and stab with your trocar cannula. It's so simple. It's like if you're used to giving intravitreal injection with a 30-gauge needle, and as Shal showed it, you just have to put it. It's so very simple. Dr. Anita, being a posterior segment surgeon, would like to have your point of view on what would you like to say that for anterior segment surgeons. And thanks very much for being with us this evening.
Oh, you're welcome. Thank you for having me. I think that was an excellent talk. Going through the post-planar and being comfortable about it is probably the most optimal way to manage any vitreous loss. I think the key thing is not to panic and to do what you're able to do. If you're not used to doing anything in the post-planar, better not try it. And the most important thing is to first close the wounds in the front. And I think for us as posterior segment surgeons, if something's going down, just let it go and leave it there and just clean up the front. And if you can easily, put an IOL in the capsule or on the sulcus or wherever else you can put in, it's a good thing, because what happens is that saves the patient another big incision back in when we go in. If you already made an incision to go into the anterior chamber, then you close that one and we again have to make a bigger incision, and depends on what lens we choose. So if it's possible, put a lens in the sulcus, even if there's some vitreous in the anterior segment, you can leave it, but we can always go and take it out. As long as the lens can stay there stably. If the lens cannot be sitting there stably, better not put it in, because if there's a piece of the nucleus at the back or something else at the back, and then this IOL tells and that goes back, then it's a lot more things to deal with the posterior segment surgeon. And I think there are a lot of other things that are important. One is, of course, to communicate the IOL calculations, because some retina surgeons are only retina surgeons and they don't have ability to do IOL calculations. So if you can send all the numbers, it's very extremely useful. And as a posterior segment surgeons, now we have a couple of choices of what lenses we can use. And I traditionally still use the CZ70 BD lens, because I like the fact that it's a PMMA lens. And if these patients have other posterior segment problems, we don't want to put a soft lens, a silicone lens, cancer and acreos. Acreos now is kind of favored by all my other colleagues, and I still haven't switched to it, and I probably won't, because of the fact that there are a lot of cases of opacification of the lens, and the Gore-Tex sutures are kind of exposed, and we'll talk a little bit about that when it comes to suturing IOLs and things like that. I think at this stage, with this amount of talks that we've had, I think the most important thing is to not, if you're not comfortable, better not go to the back. But if you are, I think it's the safest way to go through the pars plana. And getting a little bit of practice on animal eyes prior is a useful technique, so you don't have to worry about it. And I think that's the most important, and definitely not to put something into the back and try to fish the sinking nucleus. And I think that point's already been mentioned, and it's taken.
Should you be putting a posterior chamber IOL in the bag or in the sulcus if the nucleus has dropped down?
I think if the capsular rent is very small, I think putting it in the bag is fine, because the entire nucleus is gone and there's enough place to put in the bag, and the zonules are intact, and you have a very good anterior capsular opening. I think that's perfect, because we can still go and clean everything else up and there's enough support. But if there isn't enough support, then of course you want to put it in the side. I think a lot of eyes I've seen, as long as, especially if it happens at the beginning of the surgery, the entire lens goes at the back, there's only a small posterior capsular rent, and the patient can get a lens in the bag or in the sulcus, that's fine. Or like he showed, Dr. Vasvara showed that the rent occurred at the end when the lens was tilting and he was unfolding the lens and it broke, and then just leave it there. And I think that's perfectly fine. There, of course, probably the lens, the cataract has already been removed, so you don't have to worry too much about it, and we may just have to go and clean up the vitreous that's probably in the partly in the anterior segment, or partly just the rent and maybe a little bit of a tilted lens. And often patients have these lenses that are tilted. We can reposition them during our surgery, so if something happens, better to leave it alone. Even if you put an IOL and it's tilted, it's okay. We can go and play with it and put it back in the sulcus. We can always move it up to the front. The only thing that my problem now is, when I was a younger surgeon, we had choices of all these 3-piece lenses which had big diameters, big lens, and we could put in a 13.5 or a 14 or a 14.5 millimeter overall length of 3-piece lens in the sulcus. It was easy. You just go in and tuck in the modified J, and they start making those things, because all the anterior segment surgeons started using smaller and smaller incisions and smaller lenses. And the one thing that I would say is to not put any of these foldable lenses in the sulcus, especially if there's a big PC rand, because eventually it'll make it to the back. Especially if the patient needs a vitrectomy and there's no more vitreous at the back to hold it, it'll fall back at some time. And of course, nowadays we're seeing a lot of plate IOLs falling in the back many, many years later after capsulotomy and things like that. So if there's a choice of being able to put a bigger lens, it's a good idea. And I think that's probably what I would say at this stage.
Wonderful. Thanks. Which means just the message from a posterior segment surgeon is, do not be worried. Put a lens if you have adequate space within the bag or in the sulcus. Keep a bigger optic. You can also have an optic capture, either the posterior capture or the anterior capture of the lens, so that the lens stabilizes over there. That's one more thing that can be done. So don't be worried. Let the posterior segment surgeon deal with the nucleus which has been dropped back. But thanks for your input, ma'am. And Dr. Lane, sir, you teach a lot of residents, and sir, we would love to have your opinion on vitreous loss.
Now, once there is a vitreous loss, the basic thing is the anterior segment surgeon. He is very much afraid of. So he feels that something has gone wrong, and he has entered in the foreign country. So it means that is not his area. And once he is thinking like that, then everybody is, now there is a PCT. So now if in my operation theater there are 7 tables, and if there is any PCT happens anywhere, then see, they should come and tell me that, sir, there is a PCT. Sir, there is a PCT. It means their voice is also like that. So I think what Sale has just showed, it is not difficult, but yes, we always go from anterior portion, and because of that, but yes, you can do from anteriorly, but I have stopped doing anterior vitrectomy from 2 years now. I'm doing in the posterior. As you just told that it is a pars plana, and this pars plana is very easy to approach, and also the vitrectomy is also easy to do. So I think what Sale has told and has showed all the things, it is excellent, and we must now, though we are doing anterior vitrectomy from the limbal route, we should now convert to the posterior, that is a pars plana route.
Absolutely.
Thank you, Dr. Lane. Thank you very much. Gaurav, are you there, Gaurav? Okay, Partha. Yes, Gaurav.
Very much.
We would love to have your opinion on that. You know, you're one of the most dexterous surgeons that we have seen always. How do you handle your vitreous loss at various stages?
So, I think his talk was brilliant, and we've discussed some of these points, and I think we should be, anterior segment surgeons are, not even well trained, frankly, in going through the limbal approach, and, we always are hesitant, and, I think our training does not really focus on managing vitreous well in the anterior segment as well. And of course, programs where pars plana is used, they are always at an advantage because they can, typically use it. So I think one has to be proficient at both, and, depending on where your requirement comes in, one should be able to handle, small vitreous instances from the anterior segment itself and going in from the limbal approach, and then where it makes sense to go from the posterior segment. And one should not hesitate. And if one hasn't learned it, I think one must take out time and attend with somebody who's able to teach you this thing, and attend OTs with few people. It's not difficult at all. Modern machines are excellent, and techniques are good. We are lucky not to have to suture pars plana. The instrumentation has come such a long way from the time we trained that we don't need the big incisions anymore. It's all sutureless. So one should not be scared, yet one should not venture through the pars plana if you're not kind of understanding how it works.
Thanks, Gaurav. And the most meticulous man, Dr. Rohit Om Prakash. Absolutely meticulous. Rohit, some tips on this. Did you think of a sign right now while talking?
Not really. But I think we have to move on from the limbal to the pars plana one, and that goes without saying. I think we are running short of time. Should we move ahead with Lisa?
Yes. No, time is not a limit to all speakers because this is an instruction course with no time. The point is everybody who goes home should have absolute clear message what we want to. If you like to say that, otherwise we'll move on.
Yeah. Dr. Gaurav, will you introduce Lisa for the next talk?
I would request Dr. Himanshu to do that. Although I could easily do it, I'll request Dr. Himanshu to do that.
Yeah. Thanks, Gaurav. Dr. Lisa, a wonderful, passionate teacher that I have seen, always very enthusiastic, bubbling with energy, and always wants to take as much time to teach everybody the nuances of how to handle the vitreous. I think it's an excellent way to see the way she has always been so enthusiastic over the years and that we have seen her. And thanks, ma'am, for being with us this morning at a time when America is going through so much of problems, and I can understand you're spending your time from your hospital. And she is the adjunct associate professor at the University of Utah, John A. Moran Eye Center, one of the best teachers for complex phacosurgeries. And of course, she's the top 50 opinion leaders in cataract surgery, peer voted. It is PS 250 innovators in premium lens surgery worldwide. Now, if that is not enough, that shouldn't be anything more that I can say. Words fall short, but thank you for being with us, and over to Dr. Lisa. I won't take more time on that.
Himanshu, I would like to add that her course at ASCRS is one of the best attended. There's always no room to sit there, and one has to kind of reach early to be there.
Which is why we are so happy and prestigious to have her.
Thank you. Are you ready for me to share screen?
Yes.
Thank you so much for your invitation and your beautiful introduction. And it has been a pleasure to try to promote proper treatment. First of all, I think it's most important to avoid complications. And, just as you said at the beginning, there's no one who doesn't have complications, but our goal is to try to not lose vitreous the same way twice. That's our goal. Now, not everyone succeeds in that, and let's hope that this will go properly without the sound. Good. So,
I will call this Code V, Principles for Safe Anterior Vitrectomy.
Stop. I
will call this Code V, Principles for Safe Anterior Vitrectomy.
Even though I tried in the beginning and it stopped. Let's see what happens if I just go one by one. Financial disclosure. I just want to say that Shell's lecture was fantastic, and I'm almost going to be redundant in so many ways, and I'm going to keep it this way so that it doesn't.
Slideshow, madam.
Problem. Is that okay with everyone? Can you see the screen?
Slideshow.
Say that again. Well, if I do slideshow, I'm worried about the sound showing up. So let's see.
Okay, okay.
It works fine like this, Dr. Lisa.
No problem.
Perhaps it won't now. Okay, perhaps we'll be in good shape now. So there are unifying principles, and really I'm going to be quite redundant with what Shell said. My experience comes from the fact that I started for the first 10 years of my practice doing buckles, PKPs, trabeculectomy, really everything as well as cataract, and recognized that I didn't really know what to do when vitreous happened. And so Steve Charles thought we should only go anteriorly as anterior segment surgeons, and in order to show him that doing everything under a bubble was not possible, I was able to go to the lab at Utah with Liliana Warner, and that's where a lot of my principles and teachings come from. That was in 1996. There were times when I was actually not welcome at residencies to teach any of this because it was so controversial, and I'm pleased to see that we're learning more and more that the approach through the pars plana is the way to achieve these unifying principles for best outcomes, and that is avoiding intraoperative vitreous traction, preventing post-operative vitreous traction. Anything that the vitreous is attached to anteriorly at the end of a case will allow the vitreous to contract and eventually pull on the retina, which is 100 times thinner in the periphery as it is centrally, and that's why aphakic tears most often are in the periphery. Maintaining a normal tensive globe throughout surgery is really important, and the reason is that the vessels in the suprachoroidal space are and can you see me, by the way, or you have to have the slideshow to see me? Because I see you, Mohan, I don't see me.
We can see you.
We see you, madam.
You see me and hearing. Thank you very much. I appreciate that feedback. I can't see that. The point being that if the vessels in the suprachoroidal space are anchored, and when you allow the eye to go from very, very soft to very, very firm and back and forth, or allow it to be soft for a period of time, we significantly increase the risk of suprachoroidal hemorrhage. So we're really obligated to always keep a formed globe and to keep it as normotensive as possible. We want to protect tissues from collateral damage. One of the reasons pars plana is so nice is for amputating anterior-posterior connections, and so often we have a sheet of vitreous that goes over the edge of the iris through the capsule, which we end up tearing up more of our capsule and so on if we try to remove that, particularly from the anterior approach. Certainly we want to protect our cornea all the way through, and the more capsule we have, and I think finally someone mentioned the concept of optic capturing, which is so critical because at least in the US we do not have any approved larger lenses as was described any longer. That AQ series is gone, and so anything you put in the sulcus will find its way to a tear. Also, if we leave it in the bag, my feeling is that we need to convert a small tear to a continuous capsuloresis if we really hope to not potentially extend that tear in implantation. And if we have a tear once the lens is already in the bag, we can forward capture, even though that might slightly change our refractive outcome. So early recognition limits damage, and so this is why we want to be cognizant at all times of early signs of complications and be able to take care of it. Our goal should be a clean and clear anterior segment. We all know that lenticular material is antigenic, that the embryonic formation does not allow our immune system to recognize it as self, but rather foreign body. And now that we have a one-chambered eye and prostaglandins can find their way to the back of the eye easily, it's particularly important that we leave that clean anterior segment as much as possible. So our goal, and I completely agree and haven't gone into it much in here, is to clean the cortex out of the anterior segment, but anything that drops below the posterior capsule should be in the purview of the vitreoretinal surgeon. We want to implant a stable acrylic lens if possible. There are many surgeons that really don't want to see, retinal surgeons that don't want to see silicone in the eye after a PC rent. Now, the stages of complications, people think of it as, you know, complication or not. But in reality, if we're very vigilant and lucky, we might find a broken posterior capsule with a still intact hyaloid. And one way to tell that is by putting our viscoelastic through the rent. We can either see it fall backwards into the vitreous, in which case we know our hyaloid is not intact, or it will fill into itself into the space of Berger, which is delimited by Wigard's ligament, and that then we know we're in great shape to be able to convert to a continuous posterior rhexis, which even though the posterior capsule is 4 microns thick rather than say 14 of the anterior capsule, is very doable in this situation. If we have vitreous prolapse into the anterior segment, we need to call that home and remove any anterior vitreous for fear that it will create post-operative vitreous traction. Once there's vitreous loss through the incision, now it has traveled further, and vitreous behaves a little like a spring-like slinky toy. If you pull on it at the pupil, where actually if it's attached to, say, wallpaper and we're pulling on it, we're going to tear the wallpaper. In this case, it's attached to vitreous, of course, to the retina, and we don't want to tear the retina. And once it's through the incision, now we have a bigger challenge to close the eye, which is absolutely essential, especially if we're going to make a pars plana incision. And that may or may not be complicated with retained lens material.
This typical cataract with toric implant is going in an unremarkable manner. I'm protecting the posterior capsule with my second-hand instrument, supporting the chamber as I always do with BSS while removing the instruments from the eye. And that was fortunate because I now see a strangely clear area in the posterior capsule, and on testing it I see that viscoat will drop right through, indicating that in fact I have a round punch-out hole in the posterior capsule. Thinking fast, I'm using viscoelastic in this sulcus to flatten the anterior and posterior capsules to create a safe posterior capsular rhexis. We must find a little tag or make one if necessary with a scissor so that we can make a true rhexis which finishes outside of where it begins. No matter how round your punched out hole will look, it is at risk for expanding with any pressure, as it will not behave as a true created continuous rhexis will. The vector force has to be more centripetal for this very thin elastic tissue, and we will successfully complete this. That's much more difficult in the face of a ruptured anterior hyaloid, but fortunately we kept the chamber from collapsing on removing both the phaco and ina tips, and so the hyaloid never broke in this case, permitting us to go on with a completely uncomplicated case. Now that we've accomplished that, we can fill the bag and feel safe to place our toric implant. Pressure on that posterior capsule will not extend the tear because we have a true rhexis. When we go to remove our viscoelastic, we must keep in mind that we need this hole to be nicely tapenaded, holding the lens back if necessary with a second instrument while removing viscoelastic and placing myocol in the eye prior to removing the instrument to prevent any vitreous prolapse.
Don't leave an eye like this with corneal edema and elevated pressure, because our retina colleagues can't intervene in an appropriate time. So I wrote an article some decade ago or so with the concept of having code V, like we have a code blue for MIs, and that's been well emphasized already, making sure it's appropriate that you ask your machine rep to give you a one clear vitrectomy set clean that you keep, and that way you can have everybody practice. You should have a sort of vit kit available. In other words, we want the most spare instruments on our table for routine cataract surgery for efficiency, but everybody needs to know where the actual things that we might need, intraocular instruments, rings and things, all sorts of medications, and particularly Triessence from Alcon, which is the on-label acetonide that triamcinolone acetonide that we have available in the U.S. for particulate identification. I want to talk about anesthesia for just a moment, which hasn't been mentioned, and that is that if you're doing your surgery under topical anesthesia, pars plana incisions hurt. If you're going to enter the sclera, you need to offer that patient some comfort. So vitreous, of course, doesn't hurt. It can be a longer case, and so we may want to add topical anesthesia or a pledget or ring that's soaked in topical anesthesia. We want to avoid further intracameral. Not only will the lidocaine intracamerally not help, but now that we have a one-chambered eye, it will create amaurosis. The patient's lights go out, they'll freak, and you might even freak, although we were shown by Harvey Linkoff many years ago that it's not toxic to the neuroretina and they will recover within 24 hours or so. But it won't really help. Subconjunctival lidocaine bleb over the intended sclerotomy site with a couple of minutes wait is really appropriate. That's what will keep the patient from having pain when you enter the pars plana. And you can add a little epinephrine to that, which is helpful with a little bit of hemostasis. But the most important part is to have vocal local. And so in doing our code V, we can have a kind of a safe word. You know, I always used to say just timing. And when I said timing, everyone knew to stop prepping in the second room, you know, to go get the vit kit, to know that where the vitrectomy kit is handy. And the patient hears calm around them and mastery and not shouting for things, and that can be so important. Short-acting analgesics are really important, but avoid obtunding your patients because we don't have control of the airway, and they may wake up and move not knowing what's happening. If you do need akinesia in a topical case with a complication, then I recommend a subtenon's approach with a cannula, not a sharp needle with an open eye.
Don't blink or you'll miss subtle signs. You'll see in a moment the spidering of the back capsule despite protecting that capsule for the last fragment right there. And that tells us that the likelihood is we've ruptured our capsule. We need to not withdraw our phaco instrument but exchange the chopper for a dispersive viscoelastic, stabilize the situation, and inspect.
This is amongst the saddest of situations, a routine, what ought to be a routine case, but you'll see that the rise time and vacuum are too high for this unpredicted, soft, myopic lens. I'm removing anterior cortex in the usual manner and planning a vertical chop technique. As I just begin to start to come through the anterior nucleus, you'll see that tremendous change in pupil bounce, and what happened was the material came sucking through the port, bringing the posterior capsule up to the phaco needle, and we have a rupture. That tremendous change in anterior chamber depth and bounce and pupil size is a surefire sign of complication, and you'll begin to see my adrenaline surge as I replace the chopper for a dispersive viscoelastic cannula and fill the anterior chamber with viscoelastic while holding my ground with the phaco tip in place to prevent lowering the pressure and losing the chamber. Only now, when we control the chamber, can we come out, inspect, relax, and plan.
Well, particulate identification is like throwing the sheet over the ghost so that we can see what before we had to imply with air bubbles and round pupils. Unpreserved triamcinolone comes as Triessence on label in the United States. It is blocked by OVD.
Dr. Lisa, if you'd like to speak.
Dr. Lisa, you are mute, your voice.
I guess she's lost connection.
Yeah. Till the time.
Yes. Partha, would you like to talk meanwhile? Good to have you here, Partha. And Partha needs no introduction, but we have to tell him that he is the director of the BBI Foundation, Kolkata, Chairman, Scientific Committee, All India Ophthalmic Society. He's Chairman of the Academic and Research Committee of the AIOS 2014 to 17 and 17 to 19. And of course, everybody knows him as the toughest guy to fight with. You don't want to have a panga with him. Court martial in ophthalmology. So Partha is the strictest guy out there, and he can murder you and he'll convict you unless proved otherwise. So he's worse than Arnab Goswami, and I realize where Arnab got his genes from.
Thank you, sir. Thank you for that amusing introduction, sir. Thank you. So actually, listening to Lisa's talk, I'm extremely sorry for joining in late and I could not hear Shell's talk. But Lisa's talk, I just had one or two small things that I would like to ask her. And that is when a PCR occurs, she said that viscoelastic within the PC rent to go into the posterior chamber, to the posterior segment. Now, when such a thing happens, the tautness of the posterior capsule is enhanced. And thereby, since it is not yet a rexis that she has carved, so that would actually increase the length of the ear. So that was one concern that I was having without a tamponade from the anterior chamber. So it is the posterior capsule that is going to balloon up like this with the viscoelastic down, and thereby the tear would enlarge. That was one question that I would have for her. The other thing in the first video that she showed, very nicely done, the transsalon assisted vitrectomy or a transsalon at the end to be 100% sure that there is no vitreous in the anterior chamber is one thing I think all of us practice, and that's something that is done. So I'm sure maybe it is an edited video and it was not there, but it is a very, very important step at the end of anterior vitrectomy.
So Partha, what is your way when you see vitreous? What do you do? What is your control and how do you control it and what do you do?
Right. So two things, Dr. Himanshu. First is when I see a tear. So the first thing is to tamponade the anterior chamber with viscoelastic and to assess the amount of tear that has occurred and to see that it does not tear, it does not extend. So that's the first step. But of course, as you said, if it has extended and vitreous is there already in the anterior chamber within the capsular bag or beyond that, then the first thing that needs to be done is to settle the vitreous as much as possible, assess how much of the nucleus or the cortical matter is still there in the anterior chamber. If there is a large chunk of nucleus that is still there, so that has ascertained that that does not fall in through the opening of the posterior chamber. The PCR, if it is very large, then that has to be taken care of. Vitreous, if it has already come into the anterior chamber, vitrectomy needs to be done, and it has to be settled with so much that the fragments as well as the cortical matter can be removed. If it is possible, then putting in the IOL and a scaffold thereby, so that to see that it does not actually go into the vitreous cavity. After putting in a scaffold, things are much easier and the nucleus fragment can be taken off. But one possibility is always there, that the amount of cortical matter that there is, and especially if it is a pupil that is gradually constricting, so then taking out that cortical matter under the scaffold of the IOL becomes a little bit of a problem. So these are things that will have to be taken care of step by step and case by case as it comes.
I think Partha, you are also a vitreoretina surgeon. So if you drop near nucleus, do you go back and get the nucleus, fish it out yourself?
No, I don't. Actually, we have 7 vitreoretina surgeons who are dying to do this job.
Who are waiting to pounce on you.
Yeah.
And what Partha generally does not give them a choice. He doesn't give them a chance only.
Yeah. So actually, it's if a nucleus chunk falls in, it is actually the job of a vitreoretina surgeon, or if somebody is doing regular vitreoretina surgery, should attempt it, because it's not only the chunk that has come out that is to be removed, but it's also the amount of vitrectomy that needs to be done, and to see that there is no peripheral traction once the vitrectomy is complete.
I think Dr. Priya is having, Dr. Lisa is having a little problem with her connection. We could start with Dr. Priya meanwhile. Priya, would that be okay with you? And we can continue with Dr. Lisa after that, once she gets her connection back. Am I right, Rohit? Is that okay with you?
Perfectly fine. I think that should be perfectly fine. I think we need to give the brightest lady on the horizon of cataract and refractive surgery, the apt introduction. No doubt she doesn't need any introduction, but for me, she has been a source of inspiration with the number of, publications she's having. So she's director at Narang Eye Care and Laser Center in Ahmedabad, and she's a consultant for Focal Nodal Points teaching program at AO 2016. And her videos, they have been in the global video contest, which have been chosen since 2016. So that's quite a bit of global landmark, I would say. So she has been, this glue dial technique. She was the one who was responsible for taking it to the next level with the, no assistant technique. So she's reviewed in international peer-reviewed journals and in IGO too. She has quite a few books to her credit. Management of complications in phacoemulsification, the newer techniques, and the latest has been, the Mastering the Iris Repair, which will become the, the only, book handy with the surgeons across the world. She has won many medals too. I would not hold her back. So she would be speaking on pearls and pitfalls, vitrectomy for anterior segment surgeons. Over to Dr. Priya, please.
Thank you, Team IRSI. Thank you, Dr. Rohit, for this wonderful introduction. Thank you, Dr. Himanshu, and everybody in the IRSI for having me here. Thank you so much. Well, I will be covering up the topic, the pearls and pitfalls for the anterior vitrectomy. So I have no relevant financial disclosures. I will be just passing on few tips, and I'll try to make my talk as concise as possible and as precise. I will be just focusing things from the aspect of the anterior segment surgeons. So there are certain basic rules and norms which are to be followed by the surgeons, especially the beginners who have just ventured into the phacoemulsification. So I'm just going to show you a few animations to make things much more clear. This is, I'll keep on pausing as and when necessary. Now when the phacoemulsification procedure is going on, and when you have an entrapment of the posterior capsule, you have to pause down at that point of time. You need to put your foot pedal on the reflex button so that you release this posterior capsule. There is always a propensity from the surgeon to just withdraw the phacoprobe because they're so scared that, okay, my posterior capsule has been caught inside. But no, you have to deter from doing that step. Moving ahead, I would like to show that you need to hold your phacoemulsification, and please do not pull out your phacoemulsification probe. In case if you tend to have a posterior rupture, still do not worry. Remain in that position. Make a paracentesis. Take your viscoelastic. You just have to tamponade this area. Once you have tamponade and stabilized this area, and once you're quite sure of it, it is then you just pull out your phacoemulsification probe. So what I would like to say is that just try to avoid taking sudden decisions which might have a detrimental effect on the outcome of your cataract surgery. It might enlarge the rupture, or it might even enlarging the rupture means coming much more of the vitreous into the anterior chamber. So at every point of time, the basic rule is to maintain the anterior chamber and prevent it from shallowing. So this was one of the basic things. This is just a flow chart to show that if you have a posterior rupture, you need to stop aspiration, continue with your irrigation, you have to avoid the anterior chamber collapse and do not pull out the phacoprobe. Try to stabilize the anterior chamber, and it's only then you come out with the phacoprobe, and after that you suture the main incision. Take your time to decide what you want to do, because now what you do depends not only on the amount of the vitreous, it also depends upon the status of the lenticular matter or the cortex or the nucleus, whatever is present inside the anterior chamber. So then comes the decision making, which comes from you, which will result into the kind of visual outcome that you're going to have for your patient. So I will just show you one more scenario. Now, this is a case where you have a small PCR. So when you have a posterior rupture already and you have a vitreous coming up, what I showed you was when you have a vitreous which is popping up, you need to close up the anterior chamber first. So to do that, and before you pick up any other further maneuvering, you have to suture the corneal incision. Once you suture the corneal incision, the next step is put in a fluid infusion. What you are seeing here, you can use a trocar anterior chamber maintainer, you can use a simple anterior chamber maintainer, you can even use a trocar at 3 mm for fluid infusion. It all depends upon what you are comfortable with. So having done that, create a paracentesis incision as you are seeing here, and then you pick up your vitrectomy probe. Now this is a small PCR, but you are having a vitreous into the anterior chamber. If you're not very well versed with the pars plana vitrectomy, at least do something, at least do an anterior vitrectomy, clear off the vitreous from the anterior chamber, and you can get away with doing the anterior vitrectomy. So this was specifically for small PCRs. This might not work for big PCRs, which I'm going to show you right now. So I have seen many surgeons, they even do the dry anterior vitrectomy, which I do not recommend, and I even don't do that. But there are surgeons who try to do a dry anterior vitrectomy, which is specifically indicated only if there is a very small PCR. You know, there you can get away by having a cutting rate of about 500 to 700, and viscoelastic, it prevents the anterior chamber collapse. But I would try to advise you not to do that, because fluid infusion at every point of time is a must while doing this. So if you have another scenario, clinical scenario, where you have a big PCR, like you have in this situation. Now in this situation, your anterior limbal vitrectomy is probably not, it will not suffice to your needs. Because what is going to happen now is that too much amount of vitreous will be there, and it will constantly keep on bulging. And I think Dr. Shell, he showed beautifully that when you try to do it anteriorly, you know, you have much more amount of vitreous which keeps on coming from behind, and I mean, there's no stoppage of it. So what I would recommend in this situation is that after taking up the corneal suture and placing up the fluid infusion inside the eye, what you can then do is that place a trocar at 3.5 millimeters from the limbus. Now, placing the trocar, actually you have an option of using an MBR blade also, but it's always better to use a trocar, because you know these days we have those valvular trocars which you can just put up the valve out here, and when you're actually not using it, probably you can just plug it off. So but if you do not have that, you can also use an MBR and make an incision and do your vitrectomy, as again it was beautifully shown by Shell. So when you do that, what I'm now recommending is to use this pars plana incision, because you have a lot of vitreous coming up into the anterior chamber. So now what your aim here is totally different. Your aim here is to clear up the entire vitreous from behind the posterior capsule and cut down all the adhesions, leaving aside that you definitely want to clear up the vitreous from the anterior chamber, but you need to clear up the thrust which is coming from behind. So when you need to do that, you need a pars plana incision to do that. So once you have cleared up this area and you have cut down all the connections, the rest remains simple. You can again come back into the anterior chamber and you can do it, because you know at times what we do is that we can even clear up this from the pars plana incision, but it is always better to do that, because you inadvertently you don't want to enlarge this with your vitrectomy probe. So these are very fine small nuances which you know you need to follow up when you're doing vitrectomy in cases. So I'm just putting up only practical points. I'm not putting up anything much of a theory out here. The vitrectomy parameters, you all know, which has been beautifully discussed here. Try to have a good amount of cutting rate, which is very important. The cutting rate should always be more than the vacuum. You have to cut more than you suck. That's a simple thing. Because if you keep on sucking with your vacuum levels, and you're not cutting enough, and if your cutting rate is not good enough, what is going to happen is you are going to create a traction, and the traction that you create is going to have its own repercussions in your post-surgical outcomes. So you need to manage your parameters and go ahead with that. I'll just show you one or two clinical settings in the clinical video, and what I'm trying to show you here is both the do's and the don'ts, which is not to be done and which we usually do it in our clinical setting. But there are certain things which need to be avoided. Have a look at this. This is a lens, one-piece intraocular lens, which is absolutely dangling out there in the anterior vitreous. So now this trocar infusion has been placed inside, and you know the paracentesis wound has been created. And we're trying to expand this intraocular lens. Now I just pause this video here. ideally, what is now happening is that when you try to do a limbal vitrectomy from here, actually, if you see, this area of the rupture is widening itself. Already the rupture is there, but you can also see that this vitreous is coming off much more into the anterior chamber, and it is pushing this intraocular lens much more on the side. So this is going to happen. So at this stage, what actually is better to do is to go from the pars plana side and clear up the entire vitreous which is there. For here, secondary owl fixation is being done for this patient. You can also see the flaps that are being made and trying to levitate this intraocular lens into the anterior chamber. So again, I would say a pars plana vitrectomy would work much more better in this case, because you need to remove all the vitreous sedations which are there with this intraocular lens also. So that would work very well. And after you have removed this intraocular lens, the first step should be to seal up the corneal incision and then go ahead with the surgery. Now, a 3-piece intraocular lens is now being taken and secondary fixation is being done. I'll just skip this because the intraocular lens fixation is now done with the Goodall procedure. So the next step is you need to take sutures. Take as much sutures as you want, because here this sclera canal had been made and had to expand this intraocular lens. Take as much sutures as you want, maybe 3, 4, 5, whatever, but you need to have this incision sealed very well. You need not have any vitreous coming out from this corneal incision. So that part has to be taken care of it. Now what I'm trying to show you here is that having done this and you have sealed the incision, you try to analyze if there is any vitreous in the anterior chamber with the help of triamcinolone. It helps you to see the strands which normally you fail to see. Now the last step is very important, that when you see the peaking of pupil, in spite of doing a triamcinolone assisted vitrectomy, you need to, you can just swipe and see. So I just paused this video here because when it was swiped, you could just see some of the vitreous strands which are pulled towards the internal side, which are not being seen. So you need to be very careful if you see any peaking of pupil out there, because that is an indication that there is some amount of vitreous out there which probably you have missed it. So having shown you this, I just try to show you one more thing. This is the posterior polar cataract kind of thing, and you are ready because you know that this cataract has a fishtail appearance and you are going to have issues in this, so you will be ready with the surgery. So what actually happens here is that when doing the surgery, okay, the thing has come off and you have a rent, and then you go ahead with suturing of the incision, and now you have a challenge in front of you. You have the cortical matter, you have the vitreous, you have the nucleus which has almost reached into the mid-vitreous, and maybe it also goes off into the posterior side. So now actually what you have to do is you have a combination out here to do. You can either go directly from the pars plana, do the incision. Never use the main incision for doing a vitrectomy. So that is another teaching point. Never do it. This should not be followed. Make another paracentesis somewhere out there and try to take one more suture and go ahead with that. So this compiles everything, the do's and don'ts. You're removing the cortex and you have done everything out here. So once you have done vitrectomy, and once you have cleared up the entire cortex from the pupillary area, I paused this video here. You have two options now. If you are an anterior segment surgeon, you do not have a VR setup in your setting, this is the stage to refer the case to your VR friend. Do not mess around with vitreous. Do not mess around with the lens which is already lying into the posterior chamber. You have one more option. You can put in a 3-piece. You have a very good vitrectomy and there is no cortex out there. If you have done a very good vitrectomy, you can put a 3-piece intraocular lens, fix it into an optic, and you can send it to your VR colleague. If you're not confident, don't do it. Send the patient a fake cake to your VR colleague, and because your VR friend will definitely take care of the entire thing. And if you have it setting at your place, you can go ahead and do the entire posterior vitrectomy out there, take up a pars plana incision, and you need to clear up this, the posterior, the lenticular matter, the vitreous, and everything. So now what actually happens is this encompasses both the anterior and the posterior vitrectomy. If you have cases where you really feel that you will not be able to take care of, there is a drop or anything of that kind, it's always better to do this when your VR colleague is standing next to you and you have a right kind of setup to handle this complication at your place. So having done this entire procedure and taking care of the vitreous and taking care of everything out there, now this is a step where I would like to pause again once again. everything has been clear, and now you have to put up the intraocular lens. You do not visualize the anterior capsule, and the pupil has gone down. So you need to use iris hooks. Using an iris hook in the setting of the presence of vitreous is also tricky. In this case, it's not tricky because anterior vitrectomy and posterior vitrectomy, everything has been done. But in case if you have a lens matter, you have a vitreous in the anterior chamber, there is no visualization, you have to be even very careful while putting the iris hooks. Because when you're placing the iris hooks, you can again pull off the vitreous along with the hooks, and then you can create extra traction on that. So that is again a very important thing to take care of when you do your cases. In this, the iris hooks, they would work beautifully because it's an external fixating device which is out there and it's not going to fall back. Rings are not advised in these cases. Hooks, they work the best. So after clearing up everything, you can just go ahead, take up the acrylic intraocular lenses, the fixes intraocular lenses, place it, fixate it, do an optic capture, and just have a routine check of the posterior segment, seal the incision, and then you come out. So this is, I'll just try to show you one more thing, which I think
Classification for lenticular coloboma.
Yeah. I'm just trying to show you this one of the animation which most of our anterior segment surgeons, they might come across this at any point of time. So I'm just trying to focus onto this whenever we are handling cases of lenticular colobomas or maybe massive subluxations where we have an area where it is open and the communication of the anterior and the posterior chamber occurs. Under such circumstances, often, you know, what happens is that when phacoemulsification goes on, there is a continuous hydration of the posterior chamber. So what actually happens in this stage is that when you're doing a phacoemulsification, because of the hydration, the entire complex comes anteriorly, and you know you start feeling your anterior chamber is going shallow and everything. So what actually we do in these cases is we go ahead and we place up a trocar at 3.5 millimeters. This is a volvular trocar that we place, and we just do a bit of vitrectomy. It's very critical where you place the trocar, because the trocar where you place has to be seen, because you will be doing a bit of vitrectomy here. The moment you do a vitrectomy, put up some amount of vitreous from here, the depth of the anterior chamber increases and it enhances your phacoemulsification procedure. Plus, you can even, if that stage, probably if you have not put up with the hooks or the capsular hooks, you can even go ahead with that and you can stabilize the anterior chamber and do it quite effectively. So this is just one small thing which I thought that let me put this up. We just published this 2 years back, and this is how often, you know, doing vitrectomy, it really helps you even in doing phacoemulsification procedures. So I think these were just a few clinical tips that I really wanted to discuss, and the pitfalls we all know that if you do not handle your vitreous properly, probably, you know, you can end up with the macular edema. You can have retinal detachment, even you can have secondary raised intraocular pressure, and following that, you can have a sequelae of a corneal endothelial decompensation, bullous keratopathies, name it, and the complication is there in front of you if you do not happen to handle vitreous very well out there. So I think I'd like to just end my talk with that, and thank you so much for your attention. Thank you.
Very nice. Thank you, Dr. Priya, for such an excellent presentation. I think most of the surgeons in India and across the world are not fully into the posterior vitrectomy, and you have brilliantly told how we can, what is the limit to which we can do the anterior vitrectomy. The main thing which you said was, you suture it up, don't use the main port. And one very important thing which I would like to ask Dr. Lahane sir at this point of time. So you are basically an anterior segment surgeon, and most of the surgeons across are the same. What would be the approach for an anterior segment surgeon till the time he learns the posterior vitrectomy through the pars plana approach? What should be the basic limit to which he can go?
Basic, I think, very good question this, Rohit. Whenever, now see, it is not easy to learn immediately the posterior vitrectomy. When he is doing the anterior vitrectomy here, basic thing he must understand, whenever there is a PC tear, while he is coming out, he will have to follow the SOPs, that where he will have to put this tamponade. After that only he should come out. And once he puts the tamponade, then he comes out. And then now, from where he should do it, from the main port or he should do it from the side port. That is also very important. Now here the main port, if he is having, it is what port he is using, 3.2 he is using, or 2.2 he is using, or 1.8 he is using. If he is using the 2.2 or 1.8, yes, he can go from the main port. But if it is not, then he should go from the side port and he should suture the main port. If he is not suturing the main port, then that is not, that will not help him when he is doing vitrectomy, and there may be a hypotony, and that can cause some, you can say also the later on, you will see the macular, this one edema or some other things in the posterior segment also. So suturing very important, and he should do from the, you can see, and then the, of course, the triamcinolone is very important. He will have to dye this, and then he should go ahead and do the vitrectomy.
Dr. Mohan Rajan, thank you, Dr. Lahane, sir. Dr. Mohan Rajan, Dr. Lisa, we have lost her because of some communication errors. She put forth a very important thing, which I saw in the instruction courses previous years also. Code V, important kit. So do you have that, that code V, that whenever there's a vitreous loss, you should have a definite set of instrumentation or accessories ready with you, so that, ultimately, we anterior segment surgeons rarely have a posterior capsule rupture. Absolutely. And when we have that, triamcinolone is not available at times, and we are, they are searching. So kindly let us know the importance of having a ready-made kit at any point of time whenever we have a vitreous.
Absolutely. I think the Aravind has already started using this system. This is a very important system, everybody, because many anterior segment surgeons, they get, they are all very good surgeons, and they get PCR maybe once in a blue moon. So they are not very well versed in doing anterior vitrectomy or even the post-operative vitrectomy for that matter. More importantly, they may not have the equipment also to do that. And at that time, to bring the vitrector, sometimes the vitrector may not be sterilized, and they getting the triamcinolone acetate and everything. So if you have a ready-made kit, for example, we have ready-made kits for endophthalmitis, we have ready-made kits for vitrectomy, we have ready-made kits for nucleus drop. So we have got everything in place. So when we start in the beginning, we have a checklist, because any case can have a PCR, any case can have a nucleus drop. This is what I mentioned also in my FICO Master Class series in the afternoon, 3 to 4, J&J program. So any case, so in the morning when you enter the theater, make sure that you have a complete checklist, making sure that everything is available with you, and all these kits are also available with you, making sure that all your, because all the FICO machines are now equipped with the good vitrectomy systems. High cutting rate, about 3,000, 4,000, 5,000, it is available with all the FICO machines now. So it's not a problem. So it's a mental block, as Lahane sir rightly said, and all other speakers also said, it's a mental block. Initially, long time back, we were all using sponges and de-Wecker scissors for vitrectomy. Then subsequently, automated vitrector came. Then everybody started using automated, because we knew that automated vitrector is the only way to go. Now, the anterior approach or the posterior approach, which is better? Everybody knows that posterior approach has got huge advantages. We saw that in the lecture, we saw that in Priya's lecture, we saw that in Shell's lecture as well. Huge advantages. You remove less amount of vitreous when you go posteriorly. When you go anteriorly, you remove more amount of vitreous, because vitreous is like a tsunami. It will start coming into the anterior chamber. It will open up the posterior capsule. If you go behind, so this is a mental block and also a self-doubt about the surgeons that I cannot go posteriorly. It's only a matter of training everybody. It's a matter of another few years. Every anterior segment surgeon will have a kit, and every anterior segment surgeon will go posteriorly to take care of the anterior vitreous. That is my opinion.
Yeah, like in NABH training, we have code purple, this, that, so that, the patients do not come to know. So in the OT, I personally believe that you should say in a very low tone, code V, because the patient should not get fully, should not be disturbed that something deadly has happened, because in all conditions we can, control that situation. So Dr. Partha, you would like to say something about it? The calmness the surgeon has to have, the code V, and the scenario in the operation theater of the assistant, so that no, havoc is being created in the operation theater at that point of time.
Just a second before that, Rohit, since we are on the kit, Mohan, would you just expand on the kit? 1, 2, 3, 4, what would your kit have?
Yeah, absolutely.
No, we have got everything. We've got the posterior segment this thing also with us. I'm talking about an anterior segment per se surgeon. Okay, they should have kits. Yeah. For example, the PCR kit.
Yes.
The PCR kit. The PCR kit is the most important thing. And I think that is the most important thing, because that is the time when you go on searching, because everybody is in a tense, it's a tense atmosphere in the operation theater. And they will not have the vitrector, they will not have the translunar state, the cutter will not work, they will not know, as Shail was telling, they will not know how to fix up the cutter. So all these things occur. I think one important kit is the PCR kit. That is the most important complication, and which is much more thing. All other kits can be easily managed. It's not a problem at all. So we have got kits for PCR, we got a nucleus drop, and we have got a endophthalmitis set. Everything is there. So differently, yeah.
So the kit should have Transilon number 1. Correct. It should have not an ETO'd, probably the cutter, because the ETO'd, it doesn't work at times for anterior segment surgeons. A fresh piece, because we rarely have this thing. Then the staff members initially should have been trained, because anterior segment surgeons, they are not fully trained for such situations. That is the anything else which you have, so that we go into the detailing of this for the audience, what the kit should be. And that PCR
quote is very important.
Also, please understand, Himanshu, yes, the kit should have also intracameral antibiotic. Correct. Very, very important. I use intracameral antibiotic for all my patients, but there are many surgeons who don't use it for all the cases. Routine cases, they don't use intracameral antibiotic. But once you have a PCR and a vitreous loss, an intracameral antibiotic in the form of either vancomycin or amoxicillin, whatever it is, has to go inside the eye. So the kit should have everything. Sometimes you may forget that, okay? Because the endophthalmitis rate goes up by about 4 to 5 times when you have PCR and vitreous loss.
Dr. Partha, you would like to add?
Yeah, thanks. Priya's talk, as usual, was very, very good, and the demonstration through those animated videos, excellent, Priya. One thing that Priya alluded to, and which I very firmly believe, that once a PCR occurs and once there is more of manipulation in the anterior chamber and more of time taken, the pupil tends to shrink. So when that tends to shrink, you have to be sure that the pupil has to be retracted. And here, as she very correctly said, it is the iris hooks that are the best saviors in the retraction. Why? Because two things you have to see. One is your edge of the anterior capsular rexus, and the second thing is the extent of the posterior capsular tear that you have. These are the two things that you have to see. However, the vitreous in the anterior chamber and the hooks pulling out, so that the hooks would also entangle the vitreous. But is that a matter? If you have done a good vitrectomy, anterior or better, of course, a pars plana, then even if there is a tag of vitreous which is not attached to the vitreous base, it really does not matter. You might even have a small peaked pupil, a vitreous tag may be there. So you might have, but if it is detached from the vitreous base by good vitrectomy, it does not matter. So the other thing, of course, a wick of vitreous, if it is out from a wound and that wound is not sutured, or if it is the side port, which obviously you might not have sutured, again, is that a matter? So there also is not a matter to the vitreous base if it has been severed. But yes, if you have a wick out, so that can be a source of introduction of infection. So that, of course, has to be taken care of if it is popping out through a wound. So these are just a few things that I thought would be relevant.
Gaurav, how do you tackle what things you would keep ready, standby subconsciously, and your team? Please.
I know. So I think we've already discussed most of the things, but I wanted to just point out two things. One, of course, I like to use something like Viscoat, because it kind of plugs the, for the choice of viscoelastic, it tends to keep the vitreous behind. Second thing is that I think we must have a range of 3-piece lenses. There's so many surgeons who end up putting, single-piece lenses because they don't maintain an inventory. So I think all surgeons should maintain, and in fact, a few days back, I was trying to find out if any of the Indian manufacturers are making 3-piece cheap lenses, because, you end up, in fact, one of my team members in the staff, OT staff, said, every time, there's a patient, like some of our juniors are operating and they want to put in an RYCF lens, but when they have a PC rent, they end up opening a Sensor 3-piece or an Alcon 3-piece. So their package goes wrong. I said, don't worry about it. So he suggested, why don't you, buy a stock of 3-piece lenses. So I went around asking, and I came to know that Care Group has stopped making those, and I think Aurolab still makes some, but their the preloaded thing doesn't work so well. So anyway, I mean, we should maintain an inventory of all the parts, and frankly, I also maintain an inventory of retrofixated iris claw lenses. Sometimes I like to put those, and in our OT also there's a full range of, AC IOLs. So all 3 lenses are maintained for the standard parts, like from say 10 to 25 or 30, whatever. Beyond this, I think, 2 other small points which I thought are worth mentioning. Most of the times, if I have a small PC rent and if I, follow all the techniques which everybody spoke about, I'm able to convert the small PC rents into a continuous access. So that's something which I always like to do. If there is a scope for converting it into a continuous posterior access, I will always do that, because then you're secure. If you're putting in a lens, it won't expand. And most often you can do it if you stop at the right time. If you detect a PC rent at the right time before it grows bigger, and if you stop your manipulations and you maintain your chamber right with the infusion on, and if there is some vitreous which is peeking out from that small PC rent, before it makes it much bigger, you can just go into a small vitrectomy through that and clear off vitreous, and then put Viscoat or something and convert it into a rexus. So that's one second tip. And last, I wanted to just, before, I think everybody else can put in their comments, is I wanted to initiate a discussion on whether posterior levitation of the nucleus of a dropping nucleus is right, and what's the current take on it. I don't like to do it, but I would love to hear from all of you.
Yeah, Gaurav, excellent. What you said was making a lot of sense. One of the things that, common sense is reduce the speculum, just loosen up the speculum. Quite often that's pressing, and that might push the vitreous out. The easiest thing to do to start with is just see that you loosen up and you don't open the eyelid bit too much. And one of the other symptoms that we saw in Priya's videos, the pupil sometimes was peaked, and once she did the vitrectomy. So one of the common sense sign of vitreous not being there in the pupillary area is the pupil becoming more circular and closing down on you. That's one more thing that we have seen. How many of you use mannitol when you get vitreous? Would you give mannitol to reduce the vitreous volume?
You won't have time to get the mannitol going unless you have a IV lens at the time.
So, posterior levitation.
There's an upthrust, probably the mannitol.
Dr. Anita, for that matter. Dr. Anita?
Yes.
So, Dr. Gaurav, would you like to talk about posterior levitation of the nucleus, fallen nucleus, which goes behind? Are you for it?
Question was for a dropping nucleus, and which is already like in the anterior vitreous, and would you like to posterior levitate it, and what point would you decide not to levitate it?
Was the question for me, or was for the
It was for the general thing, and Dr. Rohit wants you to answer that. So
I think personally, if it's going back, you better leave it there, because the more you try to get it out, I think more complications are going to kind of ensue. And anyway, if the patient has to go to a retina surgeon, you might as well leave everything at the back and do very little to the back, and put, if you can really, I think the big pluses are, if you think it's inevitable this eye is going to go to the retina surgeon, to cleaning up the anterior part and putting a good suture and putting a lens that's stable in the sulcus if you can, those are the best thing that can be done, because what that does is it keeps the cornea clear. It makes sure that the suture is already in place, so that when the retina surgeon goes in with their trocars, they don't have to worry about putting sutures in. And the second thing and third thing is to give the patient enough steroids at the end of the surgery so that the cornea stays good, and to put them on anti-diamox or something orally, because topical obviously can't, I mean, it won't last too long if you put it in the OR and put them on Diamox and send them to the posterior segment surgeons. That's what I would do. And I think having a good cornea and having the intraocular pressure not be too high are the biggest determinants for when you can take the patient to surgery, because if the cornea is really bad and the patient's pressures are high, then sometimes the retina surgeon wants to wait to bring that down, and sometimes waiting doesn't help because it just doesn't come down. And there's a piece of the nucleus in the back, the pressure almost never comes down. And so then you're kind of fighting this battle. And in at least in the States, you know, you don't have an OR right there, and you have to you have your regular clinic, so you got to add them on at the end of the day or find some OR time. And if you're in a university, everybody else is using the OR, and so you only have your days, and so you have to do it at night and stuff, which is all fine. But to avoid all those hassles, I think keeping the pressure down, having the cornea clear are the two most important things. And if the anterior segment surgeon thinks that they can put a stable lens in the sulcus, I think that's good to put in. If you can't, just leave it. And many times I can go put on sulcus IOL without having to suture a lens if there's enough anterior capsular support. And I think those are the things I would say. I definitely wouldn't encourage trying to putting a lens rectus or one of the lens hooks or anything to get it out from the back. And if it happened and there's a big enough piece and it's still in the anterior chamber and nothing's gone at the back, I think making a bigger incision and trying to take that whole thing out, like a small incision cataract surgery is a good thing for the anterior segment surgeons, so that way they don't have the problem of letting it drop in the back. If they're trying to kind of do something with a small incision, I think the biggest worry is they don't want to enlarge the incision, and they want to try everything for the small incision. I think any of those things are not good ideas, because it's better to make a bigger incision, put a couple of sutures, and take the whole thing out from the front if they're going to, if it's a reasonable size and still in the front of the eye and there's a PC rent. And I think that would be my advice.
Fantastic.
Dr. Himanshu, there was one other aspect which I thought, ma'am is, Dr. Anita has covered up everything so well. There was a different aspect. I get referred patients sometimes where people have, vitreous presentation or a PCR, and, at whatever stage of surgery they are, the first thing they'll do is put in a lens and then, try to refer it out. So that's another thing which is very irritating, because, they'll have lots of cortex and, they won't know how the lens is. So some surgeons are so keen to just get a lens in, and somehow, moment they start encountering vitreous, and maybe if the nucleus is out, they will not bother about anything else. They won't do a vitrectomy. The lens will be all, kind of caught up in vitreous, and we'll have an IOL in place to handle as well. So I think one important thing which I would like to convey to everybody who's listening today is also to, not be too kind of enthusiastic about putting a lens unless you've managed everything really well, and you're going to put in an appropriate lens and at the appropriate place. So I think, putting the wrong lens in the wrong place and in a complicated eye actually makes things much worse. You could have a dropped IOL and a dropped nucleus to handle. So you're basically making the job of the retina surgeon worse. And I still haven't encountered a patient, who'll complain if you explain to them right after surgery that you decided not to put in a lens in the best interest of the eye. And, patients actually appreciate it, and you can tell them that, we will probably do it later, and that was in your best interest. So I think this one message also should go across.
Very important. You really don't want to hide things from the patient. If you tell them honestly, they really take it well. Sorry, Mohan, go ahead.
No. I think I fully agree with Gaurav. I think if you have a PC rent, if you're not able to know where exactly you're putting the lens, I think it's better to always wait for about a couple of weeks and then explain to the patient, and probably you're in a better frame of mind as well. And there is some fibrosis of the capsule as well. There is a fusion of the anterior and posterior capsule, and then probably you'll be able to place the lens much better in the sulcus at a later point of time, maybe after 2 weeks or so.
There is one very interesting question, that if we have a pupil snap sign after hydrodissection, how shall we proceed? Should we convert or refer to retina surgeon? This is from Dr. Mihir from Mumbai.
You want to repeat the question?
Yeah, if we have a snap sign after hydrodissection, how shall we proceed? Should we convert or refer to retina surgeon?
I think it depends on the density of the cataract, I would say.
I think step by step, if we can assess this,
Yes.
so the snap sign has occurred. And if there is no doubt about that, that means the PC is ruptured. Now, in a ruptured PC, taking out the whole of the nucleus, as Mohan said very rightly, what is the density of the nucleus is important. Whether this nucleus can be emulsified, knowing full well that it is there, the PCR has occurred. Whether this nucleus can be taken into the anterior chamber, a cushion of viscoelastic, a high molecular weight viscoelastic, placed underneath the nucleus and then very gradually emulsifying it. That option needs to be checked. But dividing the nucleus or phacoemulsifying the nucleus within the capsular bag is something that would extend whatever PC rupture is already there. So that has to be taken care of. And if gradually the nucleus is shifting down, it's very, very important. And as other speakers have said, it's not to fish that nucleus which is falling down. So wherever it is, let it stay. If it is not retrievable, let it stay. Let the VR surgeon handle it.
I apologize. I gave my entire talk not knowing you weren't there. So I apologize so much. So I just eliminated my other responsibility, and let me know if you want me to proceed now or what you want me to do.
We're all set for you.
I have never ever had such a problem. Okay, so here we go again.
Yeah, we saw the first part. We were there 1/3. We could listen to a few things.
So you'll tell me where to start again then. Let's see, share screen. And I think I figured out how to turn off the recurrent sound, so I'll just be talking through it. Do you know where I cut out?
Yes, we were here until here.
Yeah,
and,
here only. Lisa,
and even further down, on the 7th one, you went further than that. Yeah.
Down to here?
Yes.
Code vita.
Anesthesia, did we do anesthesia?
Lidocaine. Subconjunctival lidocaine is when we started losing you.
Okay. And so we're just here?
Beyond this.
Beyond this. So I'm just going to start the slideshow here. I am so sorry. I have no idea what happened. All right. So from current slide. And let's see. Can you hear?
Yes.
Yes, Lisa. We're able to see you also.
There is no video. There is no
There's
video.
No video?
There's no audio. There's no audio. So you could talk.
There's no audio. I hear the audio.
You are the audio.
Excuse me?
You are the audio.
So you don't have the audio?
No, you are the audio.
No, but
we don't have the
audio. The video is on. The video is on. You can give your talk simultaneously.
Oh, that's just dreadful. Because each one of these, I have so many, and each one is perfectly voiced over. All right. So you can't hear the audio, but I can hear the audio. I just don't understand that. Let me just see. I can't see when I have it on or off. Let's just try now. Can you hear it? Do you hear the audio?
No, ma'am.
Not too well.
It's very low.
It's very low, but it's there?
Kind of.
Yeah, very low.
Let's see if there's anything I can do about that. No, I guess it's as high as it goes.
Even though it's low.
No. I guess you'll have to give the commentary.
All right, so I'm going to have to turn it off, each one, and try to discuss it. All right, so here you go. Start over. So you don't want to blink because you want to catch complications early. You'll see a spider right now. If you saw that spider, then you know, and if you just missed that, and it's just a moment worth, and even though I have my sleeve hopefully inside, even though I'm protecting with the second-hand instrument, my sleeve probably came out into the tunnel, and that's how it shallowed. And when you see that, now you know that you have to stop and plan and look and see if there's a problem. Now you can hear this one. All right, if you don't hear this one, this ought to be a routine case. You'll see that my vacuum is high and my rise time is too high, and I'm doing a vertical chop, and you'll see that the moment that I begin to get into the capsule, you'll see what happens. Because the rise time, which was the wrong setting, this was my first day with this machine, you'll see boom, and you see that iris snap. That's a surefire sign that the pressure gradient between the anterior and the posterior segment has changed, and so that's why we get that snap. And now you'll see my adrenaline start to flow a little bit, and I know that I have a complication. It's just dawning on me what I need to do. First thing I'm going to do, of course, is to take out my second-hand instrument and replace that with dispersive OVD. While I hold my ground with the main main incision, without withdrawing my instrument. And here we're going to put the dispersive viscoelastic in, and once we get the eye normotensive with dispersive viscoelastic, now we can come out. We can make a plan and say our timing word, which we'll talk about next. By the way, Shale's talk was so fantastic that, I mean, this is almost all redundant at this point, but not every bit. Particulate identification, throwing the sheet over the ghost. We want to in the U.S., we're using Triessence because it's on label. If you're going to use Kenalog, because that's only available, it is labeled not for intraocular use, even though it is still used by many. And the main reason is that it's preserved, and so it has to be washed, and we don't use that in the U.S. anymore. I recommend that we dilute it with VSS so that we have 9 parts VSS and 1 part of the Triessence. So, and you have to resuspend it before every use. That way we can use it over and over again. Because it is blocked by OVD, in the best of all possible worlds, simply have that available all the time, and the moment you think what you would put in. But of course we already have dispersive OVD filling the eye, so it's not always all that useful at the very start. It can be useful to apply it to the outside of the eye by the incision to see if we have vitreous loss, rather than using a sponge and potentially creating some traction. And the best time to use it is really at the presumed end point of vitrectomy. So you have your irrigation, you have your vitrector, and you take out your irrigation when you think you reach the end point, leaving your vitrector in place. Put in your Triessence, and then it will swirl all around. You put your irrigation back, and you can see that you truly did reach your end point. Another time that it's most useful is before you implant your lens, because you don't want to drag a lens through vitreous. So you want to make absolutely sure before you totally fill your bag that you're in good shape, and then you can compartmentalize, putting dispersive over your tear where the vitreous is now gone, and then packing that in with cohesive. And then at the conclusion of the case, to confirm that there's no little wisp around zonules or something coming up somewhere, and also for the anti-inflammatory benefits. Now, I think Shale described anatomy so much better than I ever can, and it's important to know those facts. Do you hear this sound?
No.
No.
Okay, so I have to somehow ignore the sound. I don't know how I'm going to manage this because something's gone wrong, even though I came early to check it out. It's worked before. You want, let me turn this off here. Okay, so I think Shale made it very clear that we want no followability, and you must know your vitrectomy settings where it's irrigate, irrigate, cut, aspirate. And so therefore you have no followability. And we want to keep the globe formed with OVD whenever we're not actually irrigating, so that we keep a normotensive globe. Therefore we're always going to keep it closed, either with a scleral plug through a sclerotomy, or a stitch if necessary, a temporary tie, or now our trocar systems have valves. And we only use the IA cut when we want followability, like for cortex. I'll explain a little more about that in just a bit. So just to gild the lily a bit, the point is to avoid, to limit the sphere of influence. You know, the vitrector is a guillotine, and so it's actually creating traction in between each cut. And that's the reason that we want the fastest cut possible and the smallest influence, so the smallest gauge of cutter that we can get, and we want the lowest vacuum. And I want to go into that for just a moment, because if we did this every day, we would know when to use just enough vacuum in linear and when not to use too much. But we don't do it every day. And if you're light-footed, one of the main problems that people have is that they're actually in foot position 2, only cutting and not aspirating, and they think it's clogged because nothing's happening. Or if they're very heavy-footed, when the linear setting, which is the default, unfortunately, then they're using 500 of vacuum, which only 350 may be necessary. You don't know exactly how much to use because we're in a viscoat-filled environment or a viscoelastic-filled environment. So I recommend that you set it where it ought to be, somewhere around 350 or 400. You go pedal to the metal, having your vitrector near a little particle, and if nothing happens, you can raise it slightly. Meanwhile, you're holding your irrigation and can touch the globe and raise your irrigation accordingly to keep a normotensive globe. That way, whenever we want to remove remove vitreous, we're pedal to the metal. Whenever we want to move around and not drag vitreous, we're up in foot position 2. It's also helpful to put a detent in your foot pedal where you get a little buzz between foot position 2 and 3, and your rep can do that for you, or your settings are there to be able to do that, and then you know when you're just cutting and when you're actually aspirating the vitreous. Now, something that is different than our retina vitreous colleagues do, that I strongly recommend and has been approved by various retina vitreous colleagues, is to exhale in foot position 0. Now, if you're doing a total vitrectomy and you're coming out, you don't want a normotensive eye, so you're willing to have that little stream of fluid coming out through your little opening as you exit, keeping your irrigation on. But because we're doing a limited anterior vitrectomy, we want to exit, we want to cut all the way out, and then almost before we exit, go to foot position 0 and exit, so that we're not pushing vitreous out with our irrigation from anterior, because vitreous will always follow a gradient from high to low pressure. So your low pressure is withdrawal. If your high pressure remains irrigation, then the vitreous will follow all the more, no matter what incision you're using. And our goal is not to allow incarceration, which we'll talk more about. We went through the biaxial and the incisions, how 3.5 millimeters back. Here we have just to show a plug, and you'll see there was vitreous prolapse almost every time we come out. We're going to have vitreous prolapse, and so I'll talk for a moment about how to manage that. I don't have great video of it, unfortunately, but we want to take our vitrector and turn it upside down on the surface of the globe to remove the vitreous on the outside, and someone can irrigate from above, just dripping on it so it's not dry. And then I like to put a little bit of jot of OVD through the lips of the sclerotomy before tying the suture, ultimately, in order to avoid incarceration of vitreous. We've been through the fact it's risky business. Don't put anything but a vitrector into the posterior segment. And this is David Chang was kind enough to give me this video where he described in JCRS some years ago the idea of the visco-pal technique. Kelman first described it, but here we're putting an instrument or viscoat a cannula through the pars plana, and we do not recommend that any longer. At least I don't recommend it, and my retina colleagues don't, even though it can be effective. I went to the lab to explore this, and in this modified Miyake view, which Liliana Warner helped me with, you'll see that sometimes I would push fragments behind the iris where I didn't see them. Sometimes you can disinsert the vitreous base. You don't always get it up the way you plan. So I did make these instruments called ARVIS or nuclear spheres, which can be used through the anterior paracenteses to lift the nucleus from the posterior chamber to the anterior chamber, not the posterior segment. Let it be for the vitreoretinal surgeon to take care of if it's below the posterior capsule. But rather than levitate from the pars plana, from the posterior segment into the posterior capsule, posterior chamber into the anterior chamber, a fragment that we want to recover. We can attack those from anteriorly with these, and I have no financial interest in them. There are many ways to manipulate a nucleus. This is one that I find works for me. Now, once the fragment is raised into the anterior chamber, we want to compartmentalize it because you never want any admixture vitreous with your nucleus if you're going to remove your nucleus, particularly by phaco. Remember that we cannot phaco the vitreous. There's no way that the ultrasound will break it. It will only create traction. So if we can bring that nuclear fragment up from the posterior chamber, not the segment, posterior chamber to the anterior chamber, now we can put it on the iris, compartmentalize with Arshenov's technique of first that dispersive and then cohesive to work through, pushing it back. And now we can use a slow motion phaco technique that Osher described, preferably with bursts so that we can get that nuclear fragment right near and just go after we establish flow, since we're in a viscoat-filled environment and are at risk for a burn if we don't establish flow first. It's been described to use a scaffolding technique by Agarwal. I prefer not to put another foreign body in the eye when I don't know where things are and exactly what's going on. So I prefer to use myocol E if I have to bring the iris down, to go over the iris if necessary, with a good soft shell anterior for the endothelium. Lens glides so often will create a distal bleed, and so since you don't have direct control over it, so I don't prefer that. You can optic capture to seal the vitreous, the posterior from the anterior while you do that. We want to identify vitreous with treescence to be sure we're not doing that through there, and if in doubt, convert. Now, this is just to show you, it's a very old video. I think I'm pulling cortex, but I'm pulling vitreous around zonules. And the main reason I'm showing this is that I'm refluxing and refluxing and refluxing, and it just won't leave. And so obviously I should have, the moment I recognized it was a problem, I should have cut sharply with a scissor to relieve any traction. And that's just to so visibly show you how traction can lead to a detachment. Even the small amount of traction from the capillary action of the sponge can be an issue. If you're going to touch your wound with a sponge, have a scissor in the other hand. Do not lift it immediately. Cut it off. But better, as I said, to use treescence to see if it's there. Use the vitrector upside down and get rid of the outside so that you can suture it to make a closed eye. Rather, we want to amputate the anterior-posterior connections, which is what this is. This will show the traction, by the way, of even sweeping. So you can see when we cut vitreous, there's really no traction. But we were trained to sweep it out of the wound. And you can see here in this case that when we try to sweep it, there's actually more traction coming from posterior on the vitreous than there is getting it out of the wound. So instead, here I'm showing a Miyake view, modified Miyake with Liliana Warner, going with an anterior approach with the vitrector through the tear, and you can see how much vitreous is coming forward as well as back, just like Shale showed you. And so this is not very effective and often will lead to a whisk at the wound at the end because we've also left the low pressure anterior rather than the high pressure anterior. So instead, we're going to break the capsule, and instead of the anterior approach, we're going to, of course, use particulate identification, and you'll see that it followed an instrument that left, both instruments that left. The vitreous followed. That's why we always want to use viscoat first. But here what we're doing is we're doing the posterior approach. And what you'll see is that we completely, with the posterior approach, amputated the anterior-posterior connections. So now we can sweep it out of the wound or whack it without any pressure on the posterior, on the retina. And that's I think a good mind's eye video to keep around in your memory. Now there are many paradigms. My treatment paradigm and I want to say that that this comes from both 30 years experience as well as laboratory exploration with Steve Charles and my former partner Mike Howcroft, who's a retina vitreous surgeon, and this is where my experience or my recommendations really come from, because the more surgery we do, there were studies that showed that the fewer times we have complications, the higher our volume of surgery, and so we need to be prepared with a treatment paradigm. And so if there's a wisp around zonules, I'll simply cut it with scissors to amputate it, and then use the OVD trap or the Arshnoff reverse shell technique, keeping that always covered first with a dispersive and packed in with cohesive in which to work. If there's a small prolapse, or definitely if there's no view through the pupil, then I think we should hesitate really to do a pars plana incision as anterior segment surgeons when we have no view through the pupil, or of course, as previously discussed, if that's all you're really familiar with. And then we're always going to use biaxial incisions to fit the vitrector gauge. Never use our main incision that was meant for a sleeve, and never keep the sleeve on the vitrector. If there's vitreous loss or sheet around zonules, and I cannot depend on a closed, firm eye, then I will do a direct, I'll take down a conch Tenon's flap and do a direct MBR blade sclerotomy incision, as was discussed before, and I'll show you again in video. And that's because in order to use a transconjunctival trocar system, we must have a closed eye, and you'll see from some video the pressure that it can take to put that in, and we don't want to risk losing our intraocular contents through an incision. Now, the anterior incision must be biaxial. If you leave that sleeve on, it's the Charles sleeve, and Steve says no way did he ever intend that to be used for a complicated case. What happens is now you're hoping that a little bit of vacuum will bring the vitreous to your vitrector while you're blowing the vitreous away with your irrigation in the same place. And it will not exactly hydrate the vitreous, but displace the vitreous, go around it and bring more and more vitreous forward. So we're never going to use a coaxial approach, but rather separate. And of course, we don't want to use the primary incision, which was meant for a sleeve, and we want that closed. So instead, we'll make a second paracentesis to fit the gauge of the vitrector that we're using. And then you want to put it downwards, down through the capsule, but you saw that that may not be optimal. For pars plana, the rationale has been explained again and again because it follows a gradient to high to low. We want to leave the high anterior at all times. This minimizes traction. It's most efficient. It allows subsequent maneuvers with less likelihood of presentation. It amputates and won't unzip zonules. Once you have some zonules missing, it behaves like a zipper with the teeth off, and it's very easy to unzip the rest of the zonules, which are pulling vitreous forward, there's a tendency to do. Additionally, it will not enlarge the capsule opening as was previously described. And you saw this video. I love this video. Anyway, you saw it from Shale. This is important, and so this is just showing you all different incisions, and we're measuring 3.5 millimeters back under a flap. We're going to see, we want to aim towards the optic nerve. We see the tip of our MBR blade in the pupil, so we know we're through and through. I made that a little bigger because this is an old 20 gauge and it has a flat top, so it needed to be slightly bigger, but you won't normally do that. I talked about using the vitrector directly and a little jot of visco through there while we close. Now, I have a little difference from Shale in how I create these incisions, and this is I pull the conj back, so it's not coincidence, but I like to make a scleral tunnel incision. We want to be 30 degrees to the sclera and go intrascleral for a little while and then turn upward and push in, and you'll see the pressure it's taking here. This is an older trocar system, and then you'll see it pop back. You see how that sleeve pops back, proving that we haven't ruptured the wall or the ceiling of that scleral tunnel. And you'll see in a moment why we want that, and it might be a little extreme in this case, but we want a scleral tunnel. I'm told that I'm better off, since I learned this years ago, to use not a Q-tip, but actually even use the trocar just to punch that shut, to really grind that area shut, just like any scleral tunnel. We need it to the floor and the ceiling to come together for it to shut. Now here's the Miyake view, and you'll see the pressure that it's taking. I'm almost just inserting it from the slide, and I've done that scleral tunnel, and in your mind's eye, you'll see how it turns backwards because I have that nice scleral tunnel, and so it goes backwards according to the scleral tunnel, like the collar did, and then we can put things through. And this is a regular 3-port pars plana vitrectomy with a 23 gauge direct entry. So the reason I show this is as a light pipe comes through, you'll see when that comes back out that although in a 3-port vitrectomy it's not a big deal because we're just going to have a hypotenuse eye with fluid coming through, we're going to have tremendous incarceration of vitreous, which is why there can be a high rate of retinal tears after we do a pars plana incision if we're not careful about that. And that's why we can't leave that gaping hole, which if you make just a direct trocar incision, we have a risk of doing that. It will plug with vitreous. And the question is, will vitreous actually incarcerate? So that's the reason that I like a scleral tunnel. 30 degree, can you see that? Hopefully 30 degree entry. So if this is the sclera and the limbus, we're 3.5 millimeters back, limbus parallel, and our trocar is 30 degrees to the sclera so that we can go intrascleral for a bit and then tilt upwards and punch in. I hope that's understandable. Now, so in voiding incarceration, we're going to irrigate the sclera over the wound externally while using port down and cut the surface. And that's when we have a sclerotomy that is an open, that is an open flat sclerotomy, a direct sclerotomy. And then a little bit of viscoat or dispersive instilled through there. We'll push vitreous back, and then we can suture with a separate suture for Tenon's flap. Proper trocar insertion, then you see the scleral tunnel. This is Chris Riemann, and you can see how he's making a scleral tunnel before he goes in, and how the sleeve does not fit flat against the sclera, but is backwards, a little less dramatically than my example. Trocars are getting sharper all of the time, and so they're easier to use, but we still must absolutely be sure that we have a closed eye, that we have sealed incisions. Now, people mentioned practicing on animal eyes, but you can't really bring those into your OR because of the biohazard, and I have no financial interest, but I use this Simuli for all of my skills transfer labs at Astris and cataract telling it like it is, and at residencies at times. And so it's a great opportunity to practice whenever you like all sorts of techniques in your OR with your machines and not be afraid that it's unclean. Cortex removal, it was shown, this shows you in a traumatic case with a fibrotic capsular opening from the trauma, how I'm going to go to foot position 3 on IA cut. Not for vitreous, but foot position 3 just to make sure there's no vitreous around, then up into 2 to try to get the cortex and followability. Problem is, our irrigation and aspiration handpieces have a 0.3 opening. This is a 0.3 millimeter opening, whereas this is a 1 millimeter opening. So in a peristaltic pump, it's very difficult to get occlusion enough to build suction to get out the cortex. So it's not very efficient. And that's why, since we already have irrigation anterior, it's wonderful to use bimanual irrigation and target our cortex. And that's efficient because we have a 0.3 opening. The safest, perhaps, way to go, but uses a lot of OPD because we have to keep the eye normotensive, is to do it in a dry technique with a 26 gauge cannula and a 3 cc syringe. And what's nice about that is we have no turbulence whatsoever, no irrigation, and we can target our cortex. So if there's just a little lost, it might be worth doing it that way, but otherwise you constantly have to fill with more cohesive OVD into your bag in order to keep the eye normotensive while you remove that. Never use coaxial. So With regard to the implant, do not purposely violate both the anterior and posterior capsules. People sometimes, when they have a small capsulorhexis and nuclear material trapped in the posterior chamber, below the capsule in the posterior segment, will relax their anterior capsulotomy in order to get it up. I recommend against that. Instead, you want to do a radial cut so that you can spiral it around. So it's 5 millimeters and you can get out your nucleus, but you can still capture your optic. Since, as was discussed before, that we in the US at least don't have the AQ series 14, 13.5, and 14 millimeter haptic to haptic. I never put a lens in the sulcus without optic capture or a stitch of some kind, because the standard 3-piece lenses, by the way, are off-label for the sulcus. They're only FDA approved for the bag, even though we call them our sulcus lenses. Standard 3-piece lenses have very poor memory of their PMMA haptics and aren't wide enough so that they will tend to find their way to any tear and eventually sunset, certainly during a further maneuver by retina vitreous surgeons. Also, in my opinion, I won't put it in the bag unless I can convert to an anterior capsulorhexis, to a posterior continuous tear capsulorhexis, so that I know that that bag, that tear will not expand. Otherwise, I hesitate to put it in the bag without anterior capture from the bag to stabilize that lens. So this is the typical way of doing a nice posterior optic capture. We put our 3-piece lens, never a 1-piece in the sulcus unless the haptics are tucked down into the bag, and then we push on the poles anterior and posterior in order to capture that into that cat eye or football position. I know that pre-narrating, I hope I didn't miss my good friend's talk, but maybe you filled in with that talk while you were waiting for me. I'm kind of hopeful for you that you did. I know she'll talk about Yamini technique. Certainly, if we can't capture, iris fixation is a possibility if our iris is not damaged. I think it's really important when we talk about endophthalmitis prophylaxis. There's a 7-fold increase in endophthalmitis after we break the anterior hyaloid, not the capsule, but the hyaloid, so it's a 1-chambered eye, 14 times greater incidence, shown by Haripriya Aravind and David Chang. We know that we can reduce that incidence dramatically by using intracameral moxifloxacin, which I've used in every routine case since 2007, according to Arshinov's dictates. My habit, which is anecdotal, I have no evidence, I have no study for it, is to give 1 dose of oral 4th-generation fluoroquinolone called Avalox on discharge, or preferably if I know I'm going to be dealing with vitreous in the anterior chamber and a 1-chambered eye, I'll give it 2 hours prior to surgery, but just once, because we know it crosses the blood-brain barrier, the blood-retinal barrier, and therefore we can get a good MIC of fluoroquinolone in the vitreous cavity as well as the anterior that we're placing. And I have never had an endophthalmitis using this technique, though that is entirely anecdotal. Post-op care, we want to warn patients to accept they'll always have some floaters. We want to educate the retinal detachment symptoms so they can pick it up easily and early. There's something called the Zhang ring test from Precision Vision. I have no financial interest. It's similar to an Amsler grid in that it's a piece of paper. The Amsler grid lets you look at the center and evaluate the macula. And by the way, the patient can pick up CME themselves if instead of telling them to look at an Amsler grid for it being faded out or washed out or missing, rather wavy or missing, if you tell them, does it look as brightly black and white and washed out, they will see if they have CME that the center looks washed out, and they can actually tell you when their CME is getting better or worse. They can follow that on an answer grid with the right instruction. The Zhang ring test has a circle on a white circle on a black background with a dot, and a patient can hold it following instructions and see a peripheral retinal detachment without fail themselves early, which is a wonderful thing to empower the patient to follow the potential for complications. We want to prophylax and treat a pressure spike. Do not aggressively remove OVD as long as it's not Helon 5, a viscoadaptive. Leaving a little viscode or a little Provisc or a little cohesive in the eye. You should manually remove it, not be aggressive about automated removal. And between the fact that we may leave a little behind in that way and many other factors, there's almost always going to be a pressure spike. You want to prophylax that with either a Diamox sequel or an Alphagen or depending on sulfa allergy and other factors, because you don't want to tap the anterior chamber the next day for a high pressure spike for fear that vitreous will come forward as you lower the pressure acutely. So you want to be able to manage it medically. Prophylaxis is so much better. Timely referral to retinal surgeon, especially for retained nucleus, but there must be a good competent scleral and dented retinal exam, especially if you're going to go through the pars plana, to be sure that there's no incarceration that's causing traction at that point, and close monitoring for CME. I like to give non-steroidal as well as steroid topical medications for complicated cases. I'll continue that non-steroidal topical for a good 3 months and taper that steroid as needed. Our goal is to leave a clean anterior segment because we now have a one-chambered eye, and our goal is not to remove anything that falls below the posterior capsule, but to leave a nice clean eye anteriorly. So putting it all together, this is a old 20 gauge, but here I have a traumatic cataract with a fibrotic posterior capsule. And in taking that cortex, I believe what happened was it tore an attachment of cortical capsular adhesion, and I saw little clear reflexes, which is why I immediately filled with dispersive viscoelastic, and then I can come out, and then I use the visco to explore, and I put that through the little tear that I see, and I can see it drop posteriorly into the posterior segment, so I know that my anterior hyaloid is ruptured. And so now I'm going to completely, this is the little bit of removing cortex ahead manually with that big horse you saw briefly, a little bit of comfort for the patient with the bleb, and now we're going to measure 3.5 millimeters back. We're going to aim towards the optic nerve. We're going to see the point in the pupil to know we're through and through. We're going to come out. You've seen this this little piece before, but we'll use our vitrector. We're going to go cutting, going in, but then pedal to the metal, ideally, and adjust our vacuum and our aspiration flow and our irrigation with a low aspiration flow rate. This is edited for the sake of time, but once we think we reach our endpoint, we could come out with our irrigation and put more triescence in right now, but I'm coming out. I'm going to put the plug in because, or you'd have to temporary tie because you don't want an open globe. We're going to put OVD now into the sulcus, and we're going to try to convert that posterior tear into a continuous capsulorhexis. But because of the fibrosis of the capsule, and I didn't want to go out beyond it, I didn't totally convert it, so I'm going to put it in the sulcus. I checked again with the triescence to be sure there was no more vitreous forward, and there wasn't. So now we're putting that lens into the sulcus, and we're going to optic capture it, and then we can go about the video doesn't show this. It's a very old case, and I learned about the vitrector on the outside of the eye, so it won't show that, but rather than tie right away, we're going to remove any vitreous on the outside, put a little visco through the lips, and then first tie the main incision and then tie the outside incision. And here you can see day one post-op where that fibrotic capsular hole was that we converted to a partial, at least complete vitrectomy. And everything looks nice and quiet with a buried edovitreal knot under the conch. We don't have to bury the main knot. So in summary, recognize complications as soon as possible. A calm vocal cue like timing, that's all I say, and people know to go through the getting a bid kit and tell people not to prep in the next room for me, and it engages the team, keeps the patient quiet. We want to stabilize the anterior chamber at all times, knowing that if there's collapse, there'll be vitreous representation, and inspect and devise a plan. Separate the lens from the vitreous as best you can. Never aspirate vitreous if you can help it, using the right settings so that we limit the sphere of influence of our vitrector. Remove all vitreous from the anterior segment. Consider our IOL selection and placement, and anticipate sequelae and prophylaxis. I have a lot of this, which hopefully will be updated this year on iTube, and a Fishkind phaco complications textbook chapter. And I thank you for your attention, and I've given this now twice, and I'm glad you got to hear it at least once. Thank you.
Thank you very much, ma'am, for a wonderful presentation.
Sharing the screen. I hope I don't lose you. Stop sharing. Okay. Sharing.
Brilliant.
Stop sharing. Come on, come back. All right. And now maybe I'll be able to hear you. I have to unmute myself here. Okay.
Thank you very much for a wonderful presentation and all your time and canceling your schedule early morning out there. We missed you for a little while, but thanks for coming back. Would you like to ask some questions, Gaurav, to Lisa? And Partha, you had a couple of questions before she went off air.
Yeah.
It's my biggest IT snafu yet, this pandemic.
Lisa, can you just explain to us how you know exactly how the anterior hyaloid is ruptured or not? Can you?
Yes.
Thank you. Understand that. Yes.
I would really be happy to elaborate on that, because I think it's a unique and important point. First of all, you believe you have a tear. So you see an unusually clear reflex, for example. Now, once we have everything well controlled, now what we can do is we can take dispersive viscoelastic, put it in that area where there's that reflex, or we know there's a tear, just barely inside, and start to irrigate that viscoelastic. You can't see it well on my video because it's not 3D. But when you're looking 3D, what you're going to see is that viscoelastic will just go down. You'll see it descend into the vitreous body if there's a hole in the anterior hyaloid. Whereas if there's no hole in the anterior hyaloid, and we actually have ruptured just the posterior capsule so that Wiegert's ligament is intact, the anterior hyaloid is intact, but it's a potential space. What will happen is, as you put your visco through your cannula there and you put your viscode in, it will begin to fill into itself, because it will begin to expand Berger's space, so that you're pushing the anterior hyaloid back out of harm's way. And if you use enough of it, then you're going to see it fill into itself if Wiegert's ligament is intact. Very often old people and complicated eyes have an anterior vitreous detachment, and Wiegert's isn't totally intact, but you'll see it fill into itself and become a bubble of OVD rather than a rope headed downwards.
Very good.
Amazing.
Excellent point that you mentioned, Lisa, but I'm saying there's liquid vitreous. Quite often the vitreous is liquefied. And by the time quite a few elderly people have vitreous just walking out from your small. But
there's still an anterior hyaloid membrane if you haven't broken it, even in the most liquid of vitreous. You remember the old intracap days? I'm old enough to have done intracap. In the old intracap days, we would do a perfect case, intact hyaloid and all of that. But guess what? That vitreous body would herniate through the pupil, remember, and attach to the decimes. But the hyaloid was still intact, even though it was completely liquid, okay? So the point is that this isn't to determine, of course, in a child it's going to be different than an adult where there's liquefied vitreous, but even if there's an anterior vitreous detachment, it's not going to be 1,000%. Working, because maybe this will flow around the hyaloid into the detachment, the anterior vitreous detachment, where Wiegert's ligament is no longer attached to the posterior capsule. But by and large, Wiegert's ligament is attached to the posterior capsule. The anterior hyaloid is still intact, then it's going to be pushed backwards. Marie-José Tassignon, and I have some of her video, it'd be hard to get right now, but has beautiful intraoperative OCT where she's showing, how how the vitreous will immediately, the moment you puncture the posterior capsule on purpose for a planned posterior capsulotomy, the hyaloid will immediately come forward towards that puncture, which is why you need to use OVD to push it back. And you can see as it pushes back, no matter how liquid the vitreous is, you can see it easily flow backward. It's so easy to manipulate that anterior hyaloid and fill, and the visco will fill into itself. You're using a cohesive when you're doing this in a planned manner. You could use either one. So that's what I mean. And you'll definitely see it fall backwards if your hyaloid is not intact.
You're not going to be able to remove this later in the end. Is that okay to leave behind your disperser?
Yes, and that's a very lovely question, because especially if you're able to optic capture, then you've hermetically sealed it down below. But basically the viscoelastic that's left behind, as long as it doesn't have a way to get to the trabeculum, it's not going to cause a pressure rise. It's the anterior OVD that we leave behind that plugs up the trabeculum until it works its way through. So you can use it, leave it there. And in fact, some people even talk, Marie-José talks about the fact that our technique for planned posterior capsulotomy and optic capture, leaving that there, may actually be beneficial in some ways in filling that space so the vitreous doesn't have to you know, we almost always have a posterior vitreous separation after cataract surgery, you know, if it wasn't there before. So one of the reasons why it's very risky to do a clear lens exchange in a young myope, for example, is because if they don't already have a posterior vitreous detachment, we will create it in doing our cataract surgery, and that's because the volume of the crystalline lens is this. The volume of our regular, of our intraocular lens is that, right, is thin. And so that volume has to be compensated somewhere. And although the anterior chamber will fill with a little more a little more aqueous eventually, so does the vitreous herniate forward. And so there are some people thinking that maybe it's even a good idea to leave it if your Weger's ligament's intact, in children, for example, and so on. If your Weger's ligament is intact and your optic capture on purpose through a posterior capsulorhexis, we should maybe leave a nice volume of OVD there, because maybe it'll take up that volume that was lost.
For theoretical purpose, does that get absorbed, or does it remain like that and gel with the vitreous?
I wish I was all-knowing. I don't know, but we know that it never comes around to cause a pressure rise, and so that's really the issue. And it's just, people are just now starting to think about leaving it there on purpose. Presumably, if Weger's ligament is intact, and you know, in other words, you don't have an anterior vitreous detachment, which hardly anybody ever thinks about or talks about, theoretically it would stay, right? Because where would it get out exactly? I mean, there's a very dense zonular, posterior zonular network that attaches to the ciliary body. And you know, this business, it's kind of interesting, because this business of uniformly removing the vitreous behind the lens to prevent lens tilt, which comes from Abbe Vasavada originally, and Shale talked about this. The question is, you know, maybe that's really important, but maybe it isn't, because everything just equilibrates, you know, eventually. So I don't know that we know enough about the retrolenticular space. I think that's the future of great exploration. Even OCT shows us the anterior segment, the posterior segment does a lousy job of the retrolenticular space, and that's what we know the least about.
Dr. Anita, would you like to comment on this? Being a vitreoretinal surgeon, is that okay? Does vitreous regenerate?
Is my unmuting button here. Okay, yeah. I think it's probably going to hang around there for a little bit, but eventually it'll make its way to the vitreous, because you know, we inject lots of things into the vitreous and they all make their way out. And just because it's trapped in that little space, probably it hangs around in that space for a little bit of time, but eventually I'm sure it goes through the vitreous and gets out through uveous dural outflow.
So do you believe that the anterior hyaloid is permeable then?
Yeah,
I mean, eventually, if the anterior vitreous detaches, or that, or Rieger's ligament is detached to begin with, and definitely it would go away. But I wonder if those structures are intact, like in a child, if it would stay.
I mean, I think theoretically it probably stays there for a little bit of time, but eventually it'll probably make its way out.
It's like a gas, and I do retina surgery. Instead of leaving silicone, which you'll have to remove, why don't you leave back dispersive viscoelastic? It'll get
people have done that. Non-hypotony eyes, they filled out the vitreous cavity with Helon or any other viscoelastic and done that. It'll last for a little bit of time, but it eventually all comes out. Yeah.
Well, it's an interesting question, and actually there's some research being done on artificial vitreous. In other words, are we better to leave just aqueous to end up in there, and leave that that sort of, what we really need if we want to not create cataracts, for example, with vitrectomy, is to not have, the vitreous keeps the high oxygen at the retinal level and doesn't allow it to perfuse, in that high concentration to the lens, which is why we get nuclear sclerosis after vitrectomy. And there's research going on into whether there's something we could put into the vitreous cavity that would more mimic the activity of vitreous than the aqueous, or, the bubble that gets replaced with the aqueous, or the fluid that's left behind after vitrectomy.
Gaurav, would you like to take over?
There is one question, if I'm permitted to ask, from Dr. Gaurav. Can I ask one question which is there from the audience? Which is the first starting site of vitrectomy from anterior approach when vitreous is full of AC? Is it either from the pupillary margin first, or from the margin of side port, or from everywhere in the AC?
I'm not sure I totally understood the question. Am I to answer the question?
When would you press the suction and cutting? Suction after the cutting part, right in the center of the pupil, in the anterior?
Gotcha. So, well, maybe I shouldn't be the one to ask. Anita, would you like to answer, or I'll give my impression first? Is what I've been taught that ideally anytime we move through vitreous, we're in the cutting mode. In other words, we're going to be irrigating and cutting if we're in foot position 2. And if we have a peristaltic machine, and it's different if it's a Venturi or peristaltic, because with a peristaltic machine, we always have flow. Right? With a Venturi, the flow is linked to the vacuum. So if we have flow, then we could potentially drag vitreous around if we're only in foot position 1. And we definitely don't want to drag it around in foot position 3, so where we're aspirating. So when we're moving around, when we're moving out, we want to be cutting, and particularly through the trocar, it's a really nice idea to be cutting, but before you exit, unlike what Anita or retina people will do, we want to go to foot position 0 and then exit, so we don't have irrigation continuing to push things out. Did that answer the question? Anita, please.
For us retina surgeons, we don't have, we have 2 different ports. One is a cutting port and one is an irrigating. It's totally unconnected to each other, so we don't have to worry about it. One part I would say is, when we start vitrectomy, especially when I start teaching my fellows, when I put in the cutter, I keep the face of the cutter facing down initially, because I want, especially in an eye that has an attached vitreous, because you don't want to drag the vitreous swirls around the shaft of your cutter. So I ask them to start off this way, cut a little bit, and then go, because it's easy for us retina surgeons to see the vitreous when you have the cutter behind the vitreous. But when you first start, you can't see the vitreous, and we have an advantage with the light pipe. And of course, now I think the TriSense and the use of analog has made a tremendous difference to all of the anterior surgeons doing vitrectomy. Otherwise, I'm not sure you could at any time be absolutely confident that you've gotten all the vitreous out of the AC. And so those are small points I was going to say, was not to take your vitreous cutter in and keep the cutter facing up, because one thing is, especially when you're going in the pars plana and you don't have coaxial, like we have an advantage with the light pipe that we can illuminate from kind of tangentially. You don't want to cut this way, because if you cut it, the cutter facing top, you'll cut off the little posterior capsule that's left there. So you want to keep it down and carefully cut underneath and get the whole area cleared up, and then go and find other vitreous. That's what I would say. And, because of our machines not being similar to the anterior segment vitrectomy machines, it's hard for me to say what to keep your I won't be able to say that confidently because I don't use that. And I think if the other question, I thought that question also said if there's a whole AC is full of vitreous,
Yes.
do you want to cut at the port when you go in, or you want to go into the pupil and cut there? Because I guess the communication is from the back to the front. And I think it depends on whether you're going anterior segment or if you're going posterior segment. If you're going through the pons plana, then I would just go carefully, keep the cutter's mouth facing you so you can see it, and then carefully cut in just that plane without going dipping down or up. And because if you go up too much, you'll cut the posterior capsule. If you go too much to the below the sort of towards the mid vitreous or the more of the anterior vitreous that's deeper, you'll be cutting a lot around. First, you want to cut your port, and the important thing for us is we like to cut port first, because if you don't cut the port and you drag your cutter in, that's when you get tears behind your port, and that's an important place to check. If you have a decent view, I think you should put on the indirect and take a look at least under the port to make sure you didn't get a tear there if you can't look everywhere else. But if you can, just leave it and let the retina surgeon take a look at it the next day. And those are the points that I would say, just to not drag the shaft into the mid-pupillary area and start cutting, but just to cut carefully, and as you advance your cutter as you cut the vitreous, and so you're not kind of pulling on it.
Lisa, I had a very, very basic question to one of the issues that you brought up. That is, when there is a posterior capsular rupture, the placement of the viscoelastic or the dispersive viscoelastic, and trying to figure out whether the viscoelastic is going in a stream or whether it's spreading out, by itself would increase the volume of the anterior vitreal space, the Berger's space. And that would mean that there would be tautness of the posterior capsule, and with a small tear, my mind would say that the tear would enlarge. So if the tear enlarges, because the balance is between the volume in the capsular bag and the volume that you're placing in just behind the capsule. So if inadvertently the amount that goes in behind the capsule is more than the volume that can substantiate over the capsule, then obviously there is tautness and it would definitely tear. So that was a very, very basic question that I wanted to raise.
Well, it's a good observation. Of course, there are nuances to everything, you know, and I've never ever seen it happen. I've done planned posterior capsulorhexis and so on, and the idea is you get your anterior chamber stabilized first. And then what gives when you have this opening and you put OBD behind the opening, what gives is the anterior hyaloid. It's so diaphanous. I mean, it's incredibly thin, and so you've stabilized anterior. I've never seen any. I mean, I suppose if you had an intact Uyghur's ligament, an intact capsule, anterior hyaloid, if you pushed enough stuff in there, I don't know whether you would break the hyaloid or whether you would push the capsule up, but I have never seen tension on the posterior capsule as a result of carefully filling Berger space. And certainly if you have a broken hyaloid, it's just gonna trail downward into the vitreous cavity and go nowhere. We're not talking about putting, you know, 3 mLs of OVD in there. We're talking about, you know, a couple of minims in order to get a sense of, is it going to fill into itself and staying in one plane, you know, kind of like that, or is it just roping downward? And you can see that right away, particularly when it's liquefied vitreous. It'll just go right downward if that's open. But I see your point. Balance is everything, isn't it? And so we need to have an intact and not taut and properly normotensive anterior segment before we at all mess with that posterior segment, regardless. And so that little bit back there, I've never seen it create that. But yes, most of the time, the reason that the capsule tear expands is because we've put undue pressure anteriorly, right? And it just can wrap around zonules if it's an anterior tear and so on. So keeping the eye as much as possible in its physiologic relationships is always our goal through routine cataract surgery as well as complicated surgery. Good point.
So you fill up the anterior segment, anterior chamber, Lisa, with Viscode and then put it through the PC TET?
Yes, your very first maneuver, of course, is to fill the anterior segment. Then you're safe to come out, right? Seal your wound, and then you can go and explore, right?
Yeah, that's right.
It's part of your exploration. You know, people feel like they can't see under the iris. Well, a Kugel and hook will push the iris back. I mean, we need to explore what's going on. You know, what cortex is left, you know, where is it tear? Is it anterior, posterior? So, you know, this is one little added pearl to your exploration, your inspection of what is your status. And it's really helped me to know what's the status of the anterior hyaloid to do that little maneuver.
Beautiful.
I think it's been an amazing session. We can't hear you, Dr. Anita.
I think Anita, yeah, unmute. Anita.
I said there's a little bit of a distraction. Joe Biden's been elected president of the United States.
Yeah, we just saw that, yeah. They just announced, and I think
the whole city went in a huge cheer.
Message.
Breaking news.
I know. Yeah, that just came up on all the channels.
New York City cheered up so loudly that everybody knew about it.
You just have to survive the lawsuits and the tantrums and the whatever. Oh my gosh, I hope it's peaceful. Okay.
I think we should, we've spent almost 3 hours now. I was thinking we should kind of, before we close, and I'll request each one of you to give like one quick take-home message for the audience. We'll request Dr. Lahane sir to start first. You know, Lahane sir, one take-home message from today's session for everybody.
Yes. Now, only one tip. Whenever there is a PCTR, it is going to happen with everybody. Don't be panic. Be calm. And after that, whenever you are calm, at that time, don't remove your instrument. And once you put the tamponade, after that you remove, think twice, and then start your, whatever you want to do. You want to do it yourself or send it to others.
Wonderful, sir. Thank you so much. And we'll start now with the youngest guy in the whole group today. So, Shell, what's your take-home pearl? You know, you had lots of pearls, but one pearl that you didn't speak about.
I think the most important pearl, as has been discussed, is to deal with the anterior vitreous, whichever way you feel appropriate, whether it's limbal or pars plana, and make sure that the area of the posterior capsule there is free from vitreous and the chamber is free from vitreous, so that even if you refer it to the retinal colleague or you do it yourself, whether you do a sulcus, if you're not able to preserve the back, that's fair enough. Just place a sulcus IOL. But make sure that vitreous is free whatever way or whatever route that you use.
Excellent, Pearl, Shell. And I'll then ask Dr. Partha Biswas to give his one pearl for the audience.
Right. So we've been speaking about pearls where equipment is available and help is available. Let me speak one pearl where help is not available and equipment is not available. There, PCR, do not tread on something that you do not know. If PCR has occurred and there is a nucleus, there is some amount of nucleus that is dropping in, do not do anything if you are not sure of, if you have not done it before, if you have not read it before. Just close and refer to the vitreous surgeon.
I think that's an excellent pearl. I mean, know what you're doing and, you know, don't try new things first time. I think that's really nice. Thanks, Partha. Dr. Mohan, you know, you have a fantastic talk where you have those 10 take-home pearls. So let's hear one of them, which you thought was not covered yet.
Anticipate PCR in high-risk cases, traumatic cataracts, cataract post-vitrectomy, small pupils, pseudo-exfoliation, heart-blown cataracts. Anticipate. Have a plan A, B, C for these patients. Recognition of PCR, prevention of PCR, and also management of PCR is very, very important. One message I want to give, which I'm following, I'm doing whether you do the anterior approach or posterior approach, always separate the lens from the vitreous. Everybody, all the speakers have told, I make it a point to suture all my wounds, whether it's the main port or the side port in a PCR, when I have a PCR and vitreous loss, because I don't want infection, because the infection rates are going to be very, very high, especially when you have a leaking wound. And the micro leak, and that is a take-home message I want to give. Keep your ego on the back. That is very, very important. Make sure that the safety is more important than putting a suture.
Excellent, excellent, Dr. Thanks a lot. So now we'll have the VR surgeons, Pearl, for the anterior segment surgeons, Dr. Anita.
I think the VR surgeon is, you know, the exfoliation glaucoma is on the rise, and the second thing, it's not really the first. I mean, if you're following all these patients, you've done cataract surgery, and especially if you're an anterior segment person who does both glaucoma, secondary IOL dislocations in prior to pseudo-exfoliation eyes is on the rise. I mean, I thought I would be, the number of secondary eyes, scleral sutured IOLs that I'd be doing would be falling as time goes on. Actually, it's gone up exponentially. And so watch those eyes. These are not intraoperative cataract surgery, but, you know, patients that you've done cataract surgery maybe 10, 15 years ago, and now the lens is starting to slip and go down. So those eyes, the zones are gone, and those are the ones that need to go to the retina surgeon and for a scleral sutured IOL. And all of these have big glaucoma blebs and other things, so you have to be careful. And those are the ones that I think has actually increased my number of cases that I do. Or a lot of them are full, the entire bag, and the IOL has all, the sinking down has already sunk down. And the second thing is, you know, I had 3 patients in the last maybe like two to 3 months that had a plate IOL that was placed 25, 30 years ago, a silicone plate IOL, and they had capsulotomy sometime, and the lens fell down, and you won't believe it. Last week, I had this patient who was from 2 hours ago, had the cataract, the person who was following him had not done his cataract surgery because the cataract surgery was 30 years ago. The patient said, oh, my vision went down. They just presumed it was a central retinal artery occlusion and sent them to the ER. The ER got the neurologist involved. They got everything, a CT of his head, an MRI of his head, a carotid study, a echo, and a bubble study. And the guy just has his plate IOL in the back. And he came in to see me because as a retina person for a CRAO, his PCP sent him, said, you need to go see a retina doctor. And so he comes in, I looked at one eye, he's got an IOL in the back, and I looked, there's vitreous in the AC. I'm like, where is his IOL? So I asked him, did you wear a contact lens in this eye? He's like, no. I said, did they tell you that they put a lens in this eye? Because his vitreous was all in the AC, so I thought it had fallen long ago. But I guess it was probably he had vitreous somewhere there, and finally the lens fell in. And before I could say anything more, I put him back and I looked for the lens, and I could see it sitting on his macula, and then I put him back and I said that. So the patient told me, I told my doctor, I think it's my lens. I think I see something floating in my eye. Mm-hmm. But you know, especially in the US, we are either strict anterior segment surgeons or anterior segment doctors and posterior segment doctors. Sometimes we don't think. I think India, you guys have an advantage because a lot of you do everything. So those are advices that kind of are things that I look for. And I think pseudo-exfoliation eyes, these eyes got IOLs 10, 15, 20 years ago or 30 years ago, and now those lenses are dropping. So that's the biggest incidence, I think, of secondary.
I hope they didn't do the massage and facilitate the lens going back into the vitreous as well, thinking it's a CRO.
No, I've started putting multi-piece lenses for all the pseudo-exfoliation for the simple reason that if they dislocate later, I can just bring it up and glue it up or do a Yamane technique for these patients.
That's another point. I'll take Pearl from Lisa. Yeah.
For many years, I actually would judge the younger the age, the smaller the pupil, the more likely, you know, the hint of problems with zonulars. You get wrinkles as you try to open the anterior capsule, and the rhexis follows, and so on. For people who have any kind of significant problem with their zonules, I had been putting a 3-piece lens in the sulcus and then optic capturing with a CTR in the bag. And actually, I've only had one over the last 20 years that I think it's 16 years that fell. I looked at the video or dislocated. It didn't fall, and it was so bad I probably should have sutured it at that time. But I really believe that what happens is that when you anterior capture your lens, you prevent the phimosis, which is what over time tends to pull on those zonules. And it's true that the sulcus is partially defined by the zonule, so it isn't impossible for it to dislocate, but the bag supports the lens and the lens supports the bag, and they're extremely stable. You never see pseudophacogenesis when you've properly placed a three-piece lens in the sulcus and optic captured with a CTR in the bag. The other option is to do a planned posterior capsulorhexis and optic capture, either double capture from the sulcus into Berger space or just into the posterior capsule, where there's much less potential for the phimosis that progresses and causes these problems, which is why there's such late dislocations. I've predicted for years a real epidemic of this, and it's coming to pass. So you know, the goal is not to disturb the vitreous and to have a two-chambered eye. And if that's the case, then you, by doing the optic capture in the posterior capsule into Berger space, you can also eliminate PCO. So you don't need to disrupt things with a YAG and disrupt the anterior hyaloid. But that's a whole nother story. So yeah, I appreciate that you're saying that this is happening, and it was so predictable.
Absolutely.
And you know, Liliana Warner found that people who have no clinical of the bag lens dislocations that they looked at, quite a few actually had subclinical evidence of pseudoexfoliative material where that diagnosis was never made, and they didn't have glaucoma. So we have no idea really what the incidence of this is. So any intraoperative sign of zonular weakness along with other hint of pseudoexfoliation, I think deserves some thought of not just putting a lens in the bag.
Great, thanks, Lisa. I think we've had amazing take homes,
over
but
time.
I still have to take
a couple more closing things.
I'm sorry, no. So I'm going to ask Dr. Rohit to give one quick pearl in 5 seconds and 5 seconds to Himanshu.
I think we have to move on to posterior pars plana vitrectomy.
Very good. Thank you so much for the opportunity to present. I'm sorry I kept you in that.
Wonderful, Lisa.
And I'm so sorry I missed Priya's presentation. Tell her, please. Bye.
Thanks. Thank you very much.
Thank you.
So, Dr. Rohit, you were trying to finish off with something?
Yeah, I said that what I want to put across for all the general ophthalmologists, anterior segment surgeons, that we have to eventually move on to the posterior pars plana vitrectomy. And it's not a big deal. And it just needs that we need to reboot our mind for that.
Absolutely. I think that's an excellent message. And Himanshu, you have the final word, the guy who's behind all this. Yes.
No. Thanks, Gaurav. I would say, just do it, you can do it. That's the first thing that every surgeon, every anterior, there is a deep fear in everybody's mind that I can't do it. So just do it, you can do it. Second, the easiest way to do it is to keep going to such videos again and again and again and again. It's like jumping out from a 15,000 feet on a parachute. You know exactly how to open the parachute. You won't leave it a chance. You'll go to the videos, you'll practice. So practice, practice, practice on both sides, guinea pig's eyes, whatever you want to do. Be very clear what you're going to do, and it becomes very simple when you're prepared. Like a fire drill, it'll come subconsciously to you. I mean, at a spinal level, take it like a phacosurgeon. That's what.
Fantastic. So I think we've had an amazing session today, and I'll request Dr. Himanshu himself to thank whoever he would like to thank before we finish, and we should finish now.
Oh, let Rohit have the pleasure. Rohit, you have been a great support. Gaurav and Rohit, it's really
Dr. Gaurav, you. I think it was a brilliant idea by Dr. Himanshu to come out with vitrectomy for anterior segment surgeons. I think I've tried to cover everything, and Dr. Shal, Dr. Lisa, and Dr. Priya, they have covered practically everything, and the discussions which we had, I'm pretty sure will really help the journal ophthalmologist, anterior segment surgeon, in really finding a way in these difficult situations when vitreous appears. And with this, I would like to thank everybody for taking out their time, and that too on a Saturday evening, and that too when Trump has lost, that you're all here and wishing.
We are all celebrating.
And we have won.
And I think we should thank J&J as well for helping us organize this.
And
very nice.
Mr. Jaswinder has been such a big help, and he's ever ready to, come out and help, and you can call him at any moment, and he's there to fix things. Jaswinder ji, thanks very much, and we hope that we can further move on with other ventures as well. Thank you very much.
Thank you.
Thank you.
Special thanks to Lisa and Anita for the wonderful inputs, and we learned a lot.
Dr.
I learned a lot too.
Say hello to Joe Biden.
Joe Biden, yeah, well. Kamala Harris. Being the first woman vice president.
Fabulous.
And to Kamala from Chennai, from where I come from. Kamala from Chennai.
Yes. I mean, I don't, a woman up there is the first step. It doesn't matter what there's a woman. That's all that matters. America's taken a long time to let
and
gotta go
here.
celebrate today. Today's my day. I finished all my meetings yesterday. I had to speak to the PGI residents. The day before yesterday, I had to speak to the PGI residents. Yesterday morning, I got to speak to my residents. I had like 4 sessions, 36 hours. So I'm happy we can go celebrate.
Great. I think we
I
all
have a
got
grandson playing football.
All right. Nice. Lisa.
Bye,
Thank
everybody.
you.
Thank you.
Rohit, last
Bye. Good night. Good morning.
Dr. Lane, thank you very much for being with us till the end, from the beginning. Really appreciable with your busy schedule.
I need your blessings, sir.
Yes, I need your blessings now.
आपका आशीर्वाद है सर.
आपको अभी आशीर्वाद मुझे देना है, फिर मैं आपको दूंगा.
पूरा आशीर्वाद है, पूरा है सर. Thank you, sir.
Thank you. Thanks, Partha.
Thank you, sir.
Thank you, sir. It was very good presentation.
Thank you, sir. Thank you, sir.
How is Daddy now? How is Daddy?
He's good, sir. He's good.
Okay.
Very good presentation.
Thank you, sir. Thank you,
Rohit.
Yeah, Priya has left, is
Thank
it?
you, Partha.
Yeah,
Thank you,
Thank
sir.
you, Mansu. Thank you, Mohan.
Bye, Partha.
Thank you. Good night.
Rohit, thank you for all the help, and Gaurav, thank you so much for all the help. Yeah.
Thank you.
Manshud, bye. Thanks. Good night.
Good night.